I'm Alan Weil, Editor-in-Chief of Health Affairs. We're really pleased you've joined us this morning in conjunction with the release of the December 2019 issue focused on rural health. We have a very full agenda today to present the real richness of expertise and research and analysis included in this issue. So we're going to move through it as expeditiously as possible and keep right on time. We're scheduled to run till about 12:30 just for planning purposes. It's a good time to release an issue on rural health. It's the planning horizon for these issues is more than a year, so when you start, you never quite know what things are going to look like when the issue comes out. But I'd say topics of rural America are front and center in the public discourse, and we believe this issue makes a nice contribution to that discourse. Of course, much of that discourse focuses on the negative and challenges, and certainly as you read this issue focused on health, you'll see your share of those. But I think there are some other themes that come through, and you'll hear more about them as we go along today. For me, the primary theme here is the heterogeneity of what is defined by various organizations, as you'll hear more about in a moment, as rural, it's simply not helpful to have a single image of what rural looks like as you have this conversation. And that heterogeneity can be a barrier if we make assumptions or caricatures. As we understand it, it gives us a lens into both the challenges but also, I believe, the solutions. The second overarching theme, and I don't want to steal Jan's thunder, but her opening paper, which she will present in a moment, suggests that we need to think differently if we're going to overcome some of these barriers. I'll just leave it at that so you can talk about how differently. But that doing more of the same is not sufficient, and that there are, I'll just take the one word, structural issues that are impeding our ability to address the challenges that rural America confronts. And I think with that lens, and I'm so glad we'll be kicking off the morning with that paper, if you keep that lens in mind as you listen to all of the other work, I think it illuminates. So I'm really thrilled that that overview paper kicks off the issue. The way we hold these events when we have a theme issue is we give each author just a few minutes, 7 minutes with a timer and a hook to present their work. It's not sufficient, but it hopefully gives you a sense of what's in the issue. We encourage you to take a longer time with it as you have the opportunity to do so. After each presentation, there will be a time for just a handful of questions because we want to get through all of the material. It's always hard to organize these events because there's no single theme, but just to preview, we'll have two overview papers and then move into more topically oriented panels, one focused on access and use, one that will focus on the two papers that talk about insurance and insurance premiums, and then a handful of papers looking at health outcomes. As I say, I've said it a lot of times, but it's a real terrific collection of papers. It takes a tremendous amount of effort to put this issue together. I want to thank Jan Probst for serving as our theme advisor, helping to usher through and select and improve the papers that are presented here today. I normally quickly mention the funding support that we've received, but I think it is also worth pausing. We have a large collection of foundations, particularly some foundations that we haven't worked with a lot in the past who have an interest in rural health and were able to contribute financially to make the issue and this event possible. So in addition to the lead sponsorship of the Robert Wood Johnson Foundation, we have support from the Episcopal Health Foundation, the Colorado Health Foundation, the Kate B. Reynolds Charitable Trust, Con Alma Foundation, Empire Health Foundation, the John A. Hartford Foundation, the California Healthcare Foundation, and St. David's Foundation. And I really want to just celebrate the notion that a topic like this got the interest of so many organizations, and without their support, we wouldn't have been able to do this work. So without further ado, our first panel will be, as I mentioned, Jan Probst, Distinguished Professor Emerita in the Department of Health Services Policy and Management at the Arnold School of Public Health in the University of South Carolina. And then we'll hear from Kevin Bennett, Associate Professor in the Department of Family and Preventive Medicine at the University of South Carolina School of Medicine. They have the two overview papers in the issue, and I'll turn it over first to Jan. Come on up.
And that little buttony thing?
This little buttony thing.
Yeah, I'm really bad with little buttony things.
There it is.
All right, cool. Now, as Alan told you, I have 7 minutes to compress an article that took months to write and is as densely argued as a legal brief into key points. Pay attention. I don't got that much time. As our takeaway is in our title. A phenomenon that we call structural urbanism, and that I'm going to define for you, makes the disparities that you are going to hear about through the rest of these presentations inevitable. Or putting it briefly and in the colloquial, the game is rigged. If we don't change the game, we never win. And I've got some more detailed ways to talk about that as we go through this brief discussion. I pushed that button, right? Yes. This is one of the outcomes that we focus on in our paper. There are many in other papers. As you can see, the snapshot of this displayed in this slide is that rural residents are more likely to die at any age than are their urban peers. Why? We know the big things. People are talking about the loss of rural providers, loss of hospitals, loss of physicians, loss of a lot of other things. But I will point out, and we point out in our article, that in addition to the loss, there's the never haves and the never wills. 61% of rural counties at present do not have an OB physician. So without that OB physician, how exactly are we taking care of our maternity issues? But going on throughout the lifespan and focusing in on, for example, working age people, 62% of rural counties do not have a diabetes self-management education program. Okay? Diabetes is 10% more common in rural than in urban populations. It's a disease that you have to take care of yourself every day, and rural counties lack that basic, if you will, healthcare system piece of the built environment. And there are multiple other examples in our paper, which I encourage you to read. So why is it that rural counties don't have the things that other counties have? And what we attribute it to is what we call structural urbanism. And structural urbanism, in our perspective, arrives from funding individuals rather than funding infrastructure. The last major healthcare infrastructure program in this country was the Hill-Burton program. The Hill-Burton program targeted communities and specifically targeted rural communities, required a community assessment, and built lasting infrastructure. All of our major changes since then have been providing insurance to folks. You get Medicare. You get Medicaid. And now you may take these dollars and buy healthcare. Just as if, wait, I bought mascara yesterday because I considered this important enough to wear makeup. But that's not in the same category. The problem is that when you fund individuals, you have to have a sufficient pool of individuals to support any sort of infrastructure. And when you define infrastructure in healthcare as a voluntary purchase, like my Maybelline, you all of a sudden find out that you don't have it. And if a rural county has a great shortage of over-the-counter cosmetics, nobody cares. But when they have a great shortage of everything it takes to make a community healthy, then it's a more serious problem. So our first, I can't point. I'm a teacher, I need to point. Our first issue is that bias towards large population centers that arises from a market orientation. And there are two other issues that sort of reinforce that. One is the public health focus on national population metrics, because if you're going to move the needle, a phrase along with outside the box that I totally loathe, if you're going to move the needle, you take the big guys, and you never even look at the little guys. And we have data in our paper that points out how that is so. And the third one is ignoring innate rural barriers. There is a saying, which I'll just go to right now because there's a frightening tick down there. Equality is not the same as equity. Rural has innate barriers. There is no way that you can deal with rural without having to deal with the issues of size and distance, which are structurally different than they are in urban areas. It is very telling to me that when you read MedPAC reports, the only efficient healthcare providers are those that, quote, where's my quote? There it is. Basically don't serve rural patients. I lost the quote in my stress. But basically, you can't serve rural patients and meet a definition of efficiency that is based on urban metrics. So the game is rigged. So we need to recognize equality does not equal equity. Here is my big take home. Let's reconceptualize healthcare services as infrastructure, as we thought about it in 1947 when we passed the Hill-Burton Act. Excuse me. I'm going to choke to death. When you conceptualize healthcare as infrastructure, you make the way for things like regulated utility. Hey, you can still be private industry, but you can't, Hospital A, buy up all those little rural hospitals and close their unprofitable OB units, because we, as public utility regulators, will say you must provide that service, much the way that you must provide electric and can't decide this county has to rely on home generators, and the way we provide roads everywhere. And there is a detailed workout in our article about roads, which is that last point. If you conceptualize healthcare as infrastructure, maybe we can open our way to really creative improvements. If we have something that's adequately supported, maybe we can experiment with new designs outside the context of one or two Medicare or Medicaid waivers. And maybe we can think about a healthcare system that is connected. I was just talking to a friend yesterday. I had lunch. His wife is assisting an elderly person navigating the healthcare system because her physicians don't talk to one another. Hello, wait, I can't say that here. How crazy is that? Why do we not have a healthcare system that is, like roads, connected? So big takeaway that I want you to have in 47 seconds. We have been trying to tweak individual payments since 1977, which is when the Rural Health Clinic Act was passed. 40 plus years, and it hasn't, worked. At some point, you got to realize that continuing to tweak payment mechanisms rather than rethinking the whole deal ain't going to get us where we need to go. This is what we need. That's my take home. Think different. Go rural. We're out. And 15 seconds extra.
All right, good morning, and great, I get to follow that. I'm, like I said, I'm Dr. Bennett. I'm also at the University of South Carolina. Dr. Probst has been my mentor for 20 years. She was my dissertation chair, so it's a great honor to share the stage with her. I did not get her energy, though. So we have a commentary with several of my co-authors listed here. Dr. Kozhimannil is here with us to kind of go over this concept of what is rural anyway. And that title has carried us for, almost 2 years, I think, that we've been talking about this informally. Started off with a lighthearted joke. I think Katy's kids always guess what level of rurality they are when they're traveling, which is a fun trip thing that my family doesn't want to do for some reason. But I think it is interesting. I think it's one of those things, rural is what it is, and when you see it, you know it, but how do you actually define it? And how do feds define it? And how do other agencies define it? So there's many difficulties when you're looking at rurality or rural issues. It's a very subjective concept that we have to try to codify in a formal definition. There's multiple definitions. I think we've counted 76 rural definitions in use across the U.S. in various forms and whatnot. There are several that are more common. We'll go over in a minute. But that's a lot, and there's really not 76 ways to define rural, if you really look at it. Many data sets, especially those used for research to identify disparities, only have, if we're lucky, one indicator of rural. If we're really lucky, we have a county identifier that we can define it ourselves using some of these limited definitions, but it's really limited in what we can do. And even then, a lot of these data sets that we have just don't get enough data from rural areas. There's some large national data sets I won't name by name that actually censor communities of less than 10,000 people from their data sets. because they don't want to identify people. And so we have no idea what the experiences of those folks are and those disparities. And there's a tendency to just kind of slap a urban-rural label on things without actually trying to dig into what is actually going on there. What are those factors that cause rural to be different? And my goal when I'm doing research and doing a paper, I always want that urban-rural variable to be non-significant when I'm done, because I want to have included all the variables and all the factors that actually explain the differences. Because you can't change geography, but you can change financing, you can change infrastructure. Big picture, though, everyone has their own lens, their own perception, their own bias on what rural actually is. And here's some of the more common definitions that are used. I think if you're here, you probably are familiar with these. They go from census tract level to county level to multi-county level. And these CBSA, combined statistical area definitions, tend to be where we get into trouble, where you have truly rural counties that are included in a metro area because of commuting patterns, because of proximity, and it really limits the ability for those communities to move forward and to get the services they actually need. Talking about the people versus infrastructure argument, they're not even able to get some of the infrastructure because they're not considered rural. And the county seems to be the go-to unit of measurement. It's our workhorse in many ways, largely because that's an easy definition. It's easy to get your mind wrapped around it. Almost every data set has some sort of county designation that you can use. It's easy to conceptualize, but they don't really do a really good job of really conceptualizing communities. You could have a community on a county border that looks like they don't have anything, but all the resources are right across the county or across state lines. We have that in South Carolina with bordering Charlotte and Augusta, where it doesn't look like they have things, but they really do. But then if you're at Medicaid, you really don't, because you can't cross state lines for that. Big picture is that there's huge amount of heterogeneity across these counties. They're so different county to county, region to region. Couple examples here, this county in Arizona, Kozhimannil, I'll probably brutalized that, but that's the county that includes Flagstaff, so it's an urban county, right? But it also includes such urban areas as the Grand Canyon, okay? Native American reservations, okay? I've actually drove through there a few weeks ago, the wonderful place called Tuba City, which was wonderful, but it's all Hopi land and there's nothing there. It's 8% Native American. That's not urban, okay? This town, Mount Chase, Maine, okay? It is 100 miles from Bangor, which is the city center. 67 miles from the closest critical access hospital, not just hospital, but critical access. But it's urban because it's in a large urban county, okay, very far north of Bangor. And this is a community that can't get some of these rural services because of this designation. And obviously that's a problem that I think would all agree is a problem. I think the feds would agree is a problem, but what do we do about that? To really hammer home the point, this is urban Maine. Okay, these are literal pictures from urban counties in Maine, which if that's urban, I'm there. I'd happily live there. This is urban South Carolina. This is a town called Winsboro, okay? It's about 35, 40 minutes from Columbia, which is why it's considered urban, but it's very depressed economically. The hospital just closed because it couldn't support itself. The Walmart closed because it couldn't support itself. How many of you guys know of Walmart's closing? Okay, that's not very common, all right? So these are issues for these communities. My favorite thing is to ask people how do you define rural? We're doing a podcast where we're asking people that, and the definitions are wide and varied. We have our own definition that I won't say on camera. Is it farmland? Is it open spaces? Is it healthcare resources? But it's very subjective, and it's not really a good indicator of everything that's driving it. And I'm skipping ahead because my time is almost out. This is not a new issue, the 1938 article about rural as a spectrum, and how do you define it that way? But the takeaway that I think that we really want to stress is, can we move to defining rural not as an absence of things, absence of people, absence of built environment, but as a question of what it actually is, the strength of the features. A lot of people would love to live in rural areas because it's quiet, natural amenities, it just feels right. So can we focus on those types of things and prop that up instead of just talking about it in a deficit? So using more commonly defined terms, being aware of these limitations when we do these studies and when you read these studies, and move towards a better definition that's more index-based might be the way to go. And in our commentary, we kind of outlined what that framework might look like. That's a long process. If you're talking about federal funding, that may never happen. But it's nice to talk about and think about and start working towards those things. So that, since I'm out of time, across the finish line, there's our contact info, and read the commentary and get more info there.
I want to start with a question for Jan around the thesis that you provide. So the move to sort of individual financing had an ideological element, sort of market-based, but it also had another one, which is that institutions aren't always that responsive, and so letting people sort of vote with their dollars, let them choose, and they weren't locked into institutions that maybe weren't serving their needs. I guess my question is this a level problem, or is it a structural problem? In other words, if we gave those who live in areas where infrastructure is more expensive a bigger ticket, could we still get to the place where the infrastructure existed? Or do we really have to completely rethink this?
Well, that was complicated.
It's my job.
That is true. I'm going to try and answer that with 2 points. One is, while guaranteed service under a regulated utility can indeed vary and can elicit consumer complaints. I will say, what is the name of that company in California? Pacific Electric and Gas or something on that order? Yeah, I think people have a few issues there. Nonetheless, they have a voice through their regulators to complain about those issues. If a privately owned profit or soi-disant nonprofit hospital chain closes a rural hospital, right now there is no voice at all. Any voice beats no voice. Now the question of could you continue the tweaks we have been doing? I don't think you could continue them successfully unless the tweets had a goal, as in we have committed to retaining this service in this community, therefore we will provide the level of funding that suits that community. National tweaks that say vote with your dollars, and if you have nobody to vote for, TS, simply I don't think will work. Is that astute enough?
It's astute enough for me. It's good. Thanks. Kevin, you covered a lot of ground, but one thing that stood out for me was the censoring issue. Mm-hmm. And presumably the reason for the censoring is confidentiality, that if you provide too much identifying data for someone where there are not a lot of people, then it is possible to identify.
Sure.
So but I get the point that then it just writes them out of the data set. Right. So since we're a scholarly journal that publishes a lot of data analysis, what's the message for how to address this without undermining the confidentiality?
Well, I mean, there's a lot of mechanisms you can do for that, I think, and I think that has been abused in the past, which is why it's been locked down. There are data centers that exist across the U.S., Atlanta, North Carolina, D.C., where we used to have greater access even. We would go to the data center in D.C., the National Center for Health Statistics, and they would allow us to use the unrestricted data, the uncensored data, but then they would review the output to make sure we weren't being able to identify anybody. Even that has been pulled back to a great extent. But even greater than that, you can de-identify public use data where you don't have to identify the exact county a person lives in. You can identify the characteristics of that county. If it's a rural county, you can give it a UIC of 12. And we know, there's 3 counties in that state that has that UIC, so we don't know which one they're in. We can't identify them. And you can take other measures of, age categorization. There's a lot of ways you can really lock down the data where you really can't really identify anybody unless you know every single thing about that person anyway. So I think there's ways to not only do that, but I think oversampling rural areas in data sets is a key issue as well, where and I know it's more expensive because they're rural, it's harder to get to them, but with emerging technologies, there's no reason why we can't get greater access to that data. U.S. Census data, we have to pull the 5-year data sets together to get something, and even then the power is too low to have any useful information. So I think those are key things that we could possibly do.
That's great. We can fit one or two questions in at this stage. Is that Marilyn? I can't see. And if you could get the microphone.
Hi, good morning. Marilyn Serafini with the Bipartisan Policy Center, where we're also working on this issue like everyone right now because it's a big deal. So you had talked, Janice, about really needing to start from the beginning, start from the ground up, really rethink how we're providing health care in rural areas. And one thing that we hear over and over again is that if you're going to do that, you need to base what you have in rural areas on the community's needs. And Kevin, as you said, of course, what is a community? So if you're going to do that, how do you do that? That's where the understanding seems to stop. Is the community health needs assessment enough? Most people we talk to say it is not in its current form to really understand what the community needs. So when we're talking about not having OB in a community or not having a critical access hospital, which, by the way, we're building everything around the hospital, how do you truly, in a real way, assess what the community's needs is so that you can build from there?
That was a long and complicated question, but I'll take it anyway because I think you can endeavor to do these things. I'm going to back up. I say you do it, but you have to do it, I think, at a state level, because if you're going to implement policy, you cannot have 3,000 separate policies for 3,000 and change separate counties. But in South Carolina, the State Office of Rural Health undertook a listening program in rural communities, and it took us 18 months sending people out to talk to people in every community about what you need. Now, to do this, you have to listen with an ear and recognize what's going on. Most people who have not been sick's idea of the healthcare system comes from TV shows and hospitals and stuff like that. So you have to sort of listen to a lot of things that may not be informed, but you'll hear people talking about the problems they have with their diseases. I think you can take what you hear from the persons and have educated ears listening to them that know, hey, there's a problem, here are some of the things we could do to alleviate it. And then if you're doing it the way we did in South Carolina, then you take that, what the experts heard, back to the community and say, this is what we heard, this is what we think might work. Do you think we have captured what you want? It is possible to do. It is time intensive. Now, flipping to one other thing, I have noticed what is beginning to appear in the literature, I think, is a feeling that we have to look bigger than one person. When you have the Maryland and Pennsylvania global budget experiments, people are starting to talk about the possibility of, hey, maybe healthcare is a utility. I think we may have some motion in the direction of a utility that is attentive.
One last question here, and then we'll wait for the mic, and then we'll get.
Lou Gagliano, Coalition to Transform Advanced Care. Infrastructure is a problem. And so what should we be looking, and I guess the other thing I would say to preface my question is, there's an economic statement that says in the long term, well, we're all dead. So in the short term, what technologies really bring some answers to this issue of structural inequality that we should be looking for and trying to promote to break down the barriers ahead of when Medicare will decide they really want to deal with these kinds of problems?
I'll let him start.
I know that look. She's like, you take that one. So I think, big one that people always talk about is telehealth, right? Issue with telehealth in rural is broadband, even cell phone access. So how do we implement that? So that's a big issue. And I think there's a fundamental misunderstanding, and we kind of hit it on that in our commentary of, well, rural doesn't have this, so let's just give them this electronic solution that maybe doesn't really fit. Rural is older, lower educational attainment, and you want them to be okay with a video chat, where maybe you in an urban area wouldn't be okay with that yourself. You want to see the doctor, you want the doctor to be in the room with you, those kinds of things. But having said that, I think there is an opportunity for rural to take advantage of these technologies that are emerging. If we can solve the broadband issue, just wave a magic wand, where it can be a really good supplement. And I think it's an opportunity to, I guess, overhaul, and as Dr. Probst was saying, can we take a step back and tear it down and rebuild it in a different way? And I think rural is very unique in that way, that we can have rural communities to be these test beds of innovation, because they already are. They're trying to do everything by the bootstraps anyway. So why not blow it up, make it not physician-centric, not hospital-centric, maybe not even clinic-centric, and look at where should we deliver healthcare? Is it through a library system that some communities are working on? Through the pharmacies, we're working on that in South Carolina, where there's physical touch of pharmacists or human people of various degrees. It doesn't have to be a physician. It could be an extender. It could be a licensed nurse. It could be any number of healthcare providers. They're interfacing with the patient, but then using technology to supplement that with video tech, with video consults, so a mix of things. But we still need those acute services. We still need imaging. We still need all these kinds of services as well. But we can do it in a way that's not nearly as expensive as putting it all in a large hospital. Even the small hospitals are a lot more expensive than some of these clinics that we could set up differently. So I think taking the opportunity to look forward 20 years, everybody think back 20 years ago. How many of you had a cell phone 20 years ago? So where are we going to be in 20 years, and where can we position rural to take advantage of where we're going and really expand that services? And I think if we were to solve those things, I think some of the economics would work out as well, because I think you'll see a lot of folks moving from urban and suburban and back to these more sparse rural areas, because now you have internet, now you have healthcare, and now you have these opportunities you didn't have before. I know I probably would. I'm not going to quit my job right now, but if I could live in the middle of nowhere, I would, and connect online and do all my work that way. That would be wonderful. So I think that's where we could go. And I think a lot of states are working on that. I know South Carolina is working on that. We're working on repositioning our old TV towers to provide over-the-air broadband across the whole state. So innovative solutions to solve a problem. Then we can move forward and do something different.
Okay, I'm sorry to have to cut it here, but we have a lot more papers to get through. Please join me in thanking both of our openers. Going to ask my large second panel to start making their way to the front. We'll have a break after this, but we are not going to take a break now. Our next panel will focus on access and use. A few of the papers are around substance use and mental health, but others look at a more broad portfolio. Please don't be shy. I know it's slightly awkward to do this all on the fly. Come on up. Okay. Great. So our second panel, which is on access and use, you'll be hearing from Hayley Germack, a nurse and health services researcher at the Pitt School of Nursing, Scott Shipman, Director of Clinical Innovations and Director of Primary Care Initiatives at the AAMC, and Assistant Professor at the Dartmouth Institute for Health Policy and Clinical Practice. You'll hear from Carrie O'Hanlon, Adjunct Policy Researcher at the RAND Corporation, Michael Barnett, Assistant Professor of Health Policy and Management at the Harvard T.H. Chan School of Public Health, Leighton Ku, Professor of Health Policy and Management, Director of the Center for Health Policy Research at George Washington University, and James Kirby, Senior Social Scientist at AHRQ, the Agency for Healthcare Research and Quality, and the Center for Financing Access and Cost Trends. So you can see we have a full panel. I'll turn it over first to Hayley. Come on up.
Right. Thank you very much for the opportunity to share our findings here this morning. I also want to acknowledge my co-authors, Ryan Kandrak and Grant Martzoff. So over the past decade, we're all very well aware that there has been an increasing trend in the closure of rural hospitals. In fact, over the past 10 years, we've seen almost a doubling of hospital closures in rural counties. This is related to multiple causes, including high proportion of uncompensated care that rural hospitals are facing, in addition to decreasing operating margins. The consequences, as documented in this edition of Health Affairs, are across the board quite devastating for rural populations. We've seen quite a significant decrease in access to emergency care, a decrease in access to specialty services, including obstetric and gynecological services, resulting in significant increased time to actually accessing care to these services. We've also seen quite an increase in mortality rate. In a recent edition of NBER, there's an documented 6% increase in mortality from conditions that require urgent attention, including stroke and acute myocardial infarction following rural hospital closures. We were really interested in what this means for the local clinical workforce. What does it mean for physicians when hospitals close? We know hospitals are often quite pivotal, like institutional anchors for the physician workforce. Physicians depend on hospitals to refer patients for their expert nursing care and actually like surgical services, and hospitals depend on physicians to provide these services. So we used about 20 years of data from the Area Health Resources files to examine specifically rural counties, what happens when there's a decrease in the number of hospitals in those counties. Overall, we examined about 1,500 counties, and we looked at the impact on the overall population of physicians and then physicians by specific specialties or subcategories. Now, compared to counties that didn't experience a closure, those that did experience a hospital closure had a larger population, but to begin with, they had lower physician to population ratios. They also had lower median household income, kind of more poor health of the economy in general, and as evidenced by a greater percentage of the population living below the poverty level. We examined the effect on these counties of hospital closures in a couple of different ways. One way, we looked at the effect of the closure on this kind of overall average effect on the population of physicians. We saw across physicians of all specialties a 9.2% average decrease in the number of physicians. This for a typical like average rural county can mean a decrease in access to care for about 2,000 residents. We also saw an 8.4% decrease in the number of primary care providers. Now, providers that you typically don't think are necessarily that intrinsically related to the hospital, but indeed, following hospital closures, they decreased in population. And we saw almost a 5% decrease in the number of obstetrician gynecologists. We also looked at this temporal effect of hospital closures on the number of physicians. So we looked at the years preceding and then after a closure. Now, when it came to general surgeons, we saw that general surgeons started leaving in the 4 years prior to a closure, perhaps predicting and foreboding that hospital closure. Hospitals are quite dependent on the revenue from surgeons. Now, in the 6 years after a closure, we saw almost an 11% decrease in the supply of all physicians, including an 8% decrease in those critical community care, primary care physician providers. We also examined in a sensitivity analysis the effect of closures on counties that actually had only one hospital, and we found much more significant and devastating consequences, up to almost a 20% decrease in the supply of all physicians. Now, given that in many communities, hospitals really function as these pivotal institutional anchors, we think that thinking about the impact of hospital closures on the physician supply, we ought to pay attention to supporting and maintaining these alternative institutions that, like Kevin Bennett was referring to in the last question and answer period. We are thinking about nurse-managed health centers as potential ways to deliver healthcare in communities where rural hospitals may be closing. We also acknowledge the potential role of telehealth, but I think we also need to think outside of this health system and maybe even attend to the potential of institutions that do exist, like schools, and maybe even the role of school nurses in providing healthcare to rural communities. So thank you for your time, and I look forward to the question and answer session after the rest of the panel.
All right, good morning, everyone. Thanks so much for having me. I, too, would like to thank my co-authors from the AAMC and from Michigan State University. When you look at our title, it asserts that having fewer rural medical students poses a threat in some way to the future workforce. And that is based on two premises that I just want to state explicitly, since I won't otherwise have a chance to. First is that we have a shortage of physicians in rural communities. That's reasonably well established, and I think the previous paper underscores that. And second, that there's a strong association between students with a rural background being predisposed to practicing in rural areas. And there's extensive research over time that supported that assertion as well. Here we go. So our paper is relatively straightforward. We looked at trends in rural and urban applicants and matriculants to MD granting medical schools in the US over a 15-year period from 2002 to 2017. We defined rural background, with apologies to Dr. Bennett, in sort of a binary way, based upon county of birth and county of high school graduation, two data points that come as part of the medical school application process, the AMCAS application. We defined rural based on rural-urban continuum codes as 6 through 9, as I say, in a binary way, with labeling everyone not in that category as urban, for simplicity's sake at least. And then we additionally explored the independent effect of rural background on the likelihood of admission to medical school, and looked at that both for underrepresented racial and ethnic minority groups in medicine, as well as non-URM groups. If this figure is familiar to you, it's because Health Affairs has been kind enough to include it in the papers that you have in your lap, so I thank them for that. This is looking at matriculants or entrance to medical school over time. The horizontal axis is 2002 to 2017, that 15-year window. There are two vertical axes, one for rural and one for urban. They are at a tenfold difference in scale. And it's pretty straightforward here. You can see in blue the urban matriculants have grown significantly by 35% over that 15-year period. And that corresponds with a significant growth in medical school matriculants across the country as our medical schools have increased in number and size. But during that same period, the number of rural matriculants, rural entrants, has declined in absolute terms by 28%. Now, as promised, we also looked to try to understand how medical schools saw the rural characteristic. Was it a favorable characteristic or a liability for students? And to do that, we did a regression analysis that allowed us to control for several factors that are known to be influential in admissions decisions or acceptance to medical school. And focusing here, and I see these numbers are way too small, so let me just tell you that what we found is that medical schools, when you isolate out the rural characteristic, both for underrepresented minority students and for non-underrepresented minority students, seems to be a positive. There's an increased likelihood of admission for people with rural backgrounds, independent of all other factors. So that seems sort of quizzical, right? We have a drop in numbers even though medical schools seem to favor this. So why is that? Well, in addition to looking at the matriculant trends, we looked at the applicant trends. And in absolute terms, the number of applicants dropped by 18% over this same window of time, where urban applicants increased by 59% over that time. So there's less that are just even coming to the table to apply to medical school. That has certain implications. And then beyond that, those who do apply appear to be less competitive. Because medical schools, of course, don't isolate the rural characteristic and not look at anything else. They look at the entire package that a student brings. And there's a mismatch that seems to be growing between what the rural students are bringing to the table and what medical schools are looking for. So in conclusion, we have, again, an assumption that there's already a dearth of physicians in the rural workforce. And if we have a trend of less people coming into medicine who are the most predisposed to go practice in those areas, we're only magnifying the problem. We're only risking magnifying the problem. So to overcome this geographic diversity gap, as we've labeled it, we would need to quadruple the number of medical students from rural backgrounds. So we're not just a small ways off from where we would need to be. And it's important to point out that rural minority populations are growing, and those populations have disproportionate chronic disease burdens, as other papers in this journal, in this issue show. And yet only 1 in 200 entering medical students are from rural students from minority groups, even a more significant deficit. And so we're going to need policies that really focus on strengthening the rural pipeline into medicine, or we have to be prepared to target the workforce in other ways. And I will stop there. Thanks.
Good morning. My name is Clara O'Hanlon, and I'm really excited to be here today to represent my co-authors at the RAND Corporation, some of whom are here today, on our work on the access, quality, and financial performance of rural hospitals following health system affiliation. And just a quick caveat that none of this, this is work that's sponsored as part of RAND's Center for Health System Performance, sponsored with generous funding from ARC, but the views in here represent our views and not the views of our employers or the US government. As Hayley pointed out to you in her presentation, access to healthcare in rural areas is a huge issue, especially as rural hospital closures have become more common. One way that hospitals are seeking to try to avoid closure seems to be affiliating with a larger health system. But when you give up some local control to affiliate with a health system, there may be implications that could be good or bad for patients, but it's really not well known. So in our study, we wanted to examine the relationship between health system affiliation and rural hospital performance. And the way that we did this was by looking at differences in performance between rural hospitals that affiliated with the health system between 2008 and 2017, and compared it to performance characteristics for a set of hospitals that were non-affiliating during this period, and weighted for characteristics so that they were similar to the ones that did. We looked at a bunch of different measures in the paper, but I'm only going to highlight 7 of them today. We tried to bring together a bunch of different data sources to look at this from a broad perspective, looking at structure, so services provided on site. We looked at an imaging technology composite, which was a count of imaging technologies that are available on site. We looked at whether or not OB services were available on site, as well as primary care on site. Looked at outpatient visits, operating margins, and 2 pretty broad measures of quality. The first being a patient experience composite, which is a composite of 9 measures that is put together the way that the star ratings are, and then 30-day all-cause readmissions. And we went in with some hypotheses about this. We thought that hospitals would be likely to consolidate services up to somewhere else in the health system. So we thought might be less likely that they'd have imaging technologies on site, and less likely that obstetrics would be on site. But we thought that primary care, since that's something that is thought to be referral increasing, a major motivation of health systems acquiring or affiliating with rural hospitals is capturing those referrals. So we thought that anything that might increase referrals would, if anything, go up. We thought accordingly outpatient visits would increase, and that operating margin we thought there would be an increase as well, since this is a major motivation of affiliation. And lastly, because health systems have greater resources for potential quality improvement, we thought that quality would improve as well. And in some cases, we found what we expected. It does appear that affiliation with a rural hospital does lead to a decrease in the imaging technologies available on site. We found about a 0.3 decrease, which is the equivalent of like 1 in 3 rural hospitals removing one imaging technology. We saw a pretty large decrease in obstetric care services. This has been pretty well documented in the news as well. But what I think was really surprising is that we saw a decrease in primary care departments available on site at these institutions as well. And we're not sure whether this reflects a moving to some kind of outpatient facility, and so it's just a change in the accounting of whether outpatient care is available in the community or somewhere else, or if it actually does represent a reduction in access. We did observe an according decrease in outpatient visits all around, pretty significant one. And we did observe an increase in operating margin. And this is in conflict with a previous study that looked at the effect of affiliations on rural hospitals. But that study found that it did not increase and actually decrease, but we used a different control than they did. So that's something we discussed in the paper. And then lastly, we observed no significant differences, positive or negative, with either of the measures of quality that we looked at. We really wanted to look at a lot more measures of quality, but due to data reporting differences with small hospitals, things like that, actually becomes really hard to study quality at scale in little hospitals. So overall, our implications, we found that rural hospital health system affiliation is increased with increased operating margins. But it might also result in reduction of local access to certain services. But since we were only able to look at on-site services, the extent to which this reflects actual care not being provided or care being received, we can't say anything about that in this study. And lastly, it doesn't appear to be associated with improvements in these pretty broad measures of healthcare quality. So even if health system affiliation prevents rural closure, and we don't know whether or not it does, it may not actually still be preserving access to local services in rural communities. Thank you.
All right. Good morning, everybody. It's great to see such a full crowd for this briefing, and it's my pleasure to be able to present our paper. I'd like to acknowledge my co-authors, Dennis Lee and Dr. Richard Frank, who's at Harvard Medical School. So my paper centers on addiction treatment in rural America, and I am sometimes the tone of, I think, the papers in this issue and in rural health in general can be a bit gloomy, but actually today I'm going to be presenting what we view as really a policy success in terms of rural health. The major problem that we are interested in studying here is that access to evidence-based treatment for opioid use disorder across America, but particularly in rural areas, is very limited. And in particular, we were looking at access to buprenorphine, which is a life-saving treatment for opioid use disorder that is accessed by only a small minority of individuals with opioid use disorder, or OUD. 56% of rural counties in 2016 did not have a single prescriber who was authorized to actually distribute or prescribe buprenorphine. And there's a number of reasons why these barriers exist. First is that there's a shrinking physician supply, as many have mentioned, but also there's an onerous federal requirement to get 8 hours of training to actually acquire one of these waivers for a physician. So one major change in policy that had the potential to actually improve this status quo was the Comprehensive Addiction and Recovery Act, or CARA, that was passed at the end of the Obama administration. And what this act did was that beginning in 2017, it allowed nurse practitioners and physician assistants, or NPs and PAs, to be able to apply for one of these buprenorphine waivers to prescribe this life-saving medication. They had to receive 24 hours of training and jump through a number of hurdles, but it enabled that to happen. And given the importance of NPs and PAs for the rural healthcare workforce, the CARA Act really had the potential to expand access. So what we did is we took a comprehensive federal database of every provider in the country that has received a buprenorphine waiver up through 2019 to examine the adoption of these waivers by NPs and PAs, particularly with a focus in rural America. So what we found was that beginning in 2017 and by 2019, there's really an explosion of waiver adoption by NPs and PAs. Over 12,000 of these providers obtained buprenorphine waivers by March 2019. And remember here, this requires 24 hours of training that nobody's paying for, as well as a number of hoops to jump through to actually get your DEA license. This map here shows the pattern of adoption across the country, with the darkest blue showing counties that have the highest quartile of NPs and PAs adopting buprenorphine waivers. In these counties that had the highest adoption in rural areas, 1 in 4 NPs and PAs actually acquired one of these waivers. By 2019, actually 286 rural counties with close to 6 million rural residents acquired their first buprenorphine prescriber in their home county. This is a reduction of about 36%. And also, the majority of growth in the capacity for buprenorphine to be prescribed in rural counties came from NPs and PAs. So one issue, though, is that state policy can get in the way. So one major set of state regulations and policies for NPs and PAs is scope of practice. And so in many states, NPs and PAs don't actually have the authority to independently prescribe and practice in whatever way they want. They have to be supervised by a physician or have some kind of collaborative agreement. So what we did is we compared the adoption of buprenorphine waivers among NPs and PAs in states that did have independent full scope of practice versus those where it was restricted. What you can see here is that nurses are represented in yellow, with the full scope of practice as a solid line, and the dotted line showing restricted practice, and then PAs are in green. What you can see is that most of the adoption was really through NPs, and that in rural areas, by the end of 2019, twice as many NPs had obtained waivers in states with more permissive scope of practice than those with restricted scope of practice. And PAs who acquired these waivers at a lower level, scope of practice seemed to make less of a difference. So the policy implications for our results are that I think the CARA legislation really achieved its goal of trying to expand access to buprenorphine waivers in rural areas, and the mechanism was through NPs and PAs. One very important limitation to our research is that we weren't able to actually look at prescribing itself. These waivers can really just be interpreted as the intention to prescribe, and that's future research that needs to happen. But I view this rapid adoption as really another demonstration of the importance of non-physician clinicians, advanced practice providers in rural healthcare, as well as the dedication of these providers over this period of time to go through what is really an extremely kind of onerous process of training and paperwork to get these waivers. Scope of practice did have a strong association with NP but not PA adoption of these waivers, and we hypothesize that I don't think independent scope of practice necessarily promoted adoption of the waivers, but rather restricted scope of practice inhibited NPs that wanted to from actually getting those waivers. This is another example where what seems like an effective federal policy kind of collides with state regulations and policy and creates a more complicated environment. All right, so I'd like to stop there. Thank you all for the opportunity to speak today, and looking forward to the discussion.
Good morning, I'm Leighton Ku. Others have thanked their co-authors. Actually, I should mention that on this particular paper, Xinshin Han, who really did most of the work. I'm sort of the lowly co-author, essentially. Xinshin, though, after completing her PhD here at George Washington University, has gone on to a prestigious postdoc at the leading medical school in China. And among more important things, actually, now has rejoined her husband, who she hasn't lived with for the past 2 years. So the point of this really is no tough questions, please. So how do I advance this? So in this particular paper, we're really talking about some of the issues and gaps that relate to mental health care in rural areas, though I'll mention we're focusing primarily on access and issues that relate to community health centers and also the role of the National Health Service Corps. And if you know about those programs, both those programs basically are premised on the concept that we're really here to provide more care in underserved areas. So really we're dealing with, both in urban and rural areas, sort of areas that lack a sufficient healthcare infrastructure. And we certainly realize that behavioral health problems have become a serious issue, a serious problem. I'm sure we've all heard about the deaths of despair. There was great news about this coming out just recently about some of the high mortality that's associated essentially with a number of behavioral health issues. So one of the things I want to point out within this particular graph is sort of talking about sort of what do we know about behavioral healthcare staffing in community health centers, and then in particular then also what's the role of the National Health Service Corps. So what we see is, and again, these are in underserved areas, the good news is that over the period 2013 to 2017, there's been consistent growth in behavioral health staffing, and I'll tell you what I mean by that in just a moment. It is still somewhat lower in the rural areas, and that's the red line at the bottom, than in the urban areas. But on the other hand, the growth in the rural areas has been a little faster. And so part of this has to do with deliberate actions that HRSA has done in terms of trying to provide sufficient funding to bolster behavioral health care access, but some of it is also the demand. Health centers have grown a lot because of the Medicaid expansions, and so part of it is also the understanding of what are the needs in their communities. One of the things I'll mention that might also sort of explain, at least in part, some of the higher use of behavioral health staffing in urban areas. Partly it's probably just that it's easier to get some of the staff in urban areas than in rural areas, but it also because a number of community health centers are focused on things like care for the homeless who have particularly high rates of mental health problems. So that may be part of it. In total, the community health centers have, roughly speaking, 12,000 behavioral health care providers that they've added into communities in underserved communities. So that's a substantial increase in access to care and the providers that are there. The National Health Service Corps is providing about 10% of those providers. However, the growth rate of the National Health Service Corps staff has grown faster also than the general trend. So again, in this case, to what extent we understand the role of the HRSA programs, they've really been trying to move the needle, I hated to use that phrase that was just criticized just a moment ago, in sort of getting access in that area. So the next issue is, so who are we talking about by these behavioral health care providers? Typically, at least many of us, when we think about behavioral health, we think of psychiatrists, maybe to a lesser extent psychologists. That's not who most of the staff are. If you look at the bar charts that are in here, the staffing, the psychiatrists are the little blue part way at the left end, and they comprise, roughly speaking, about 9%, whether you're talking urban or rural. The red part of the psychologists, so that's a slightly larger share. But the bulk of the workforce is this green sector in the middle, and those are licensed clinical social workers. So they're the people who are providing the bulk of the services. The purple part next to that are substance use therapists, and then the blue area are other licensed therapists, people like marriage and family therapists, others who are in that field. So this is similar to, in a way, to what Michael Barnett was just saying, where we sort of think, gee, all the action is in terms of doctors. Actually, again, in the health centers, really it's sort of the non-doctoral staff who are providing so much of the bulk of that services, and they're really sort of the main workforces in this area in terms of making sure that the activities are done. So the final thing, and so of course we had to do some fancy analysis. So, and by the way, I should mention, this is largely using administrative data, the uniform data systems, and information about National Health Service Corps staffing supplemented with some census data and area health resource file data. But so in total, the community health centers provided about 10 million mental health visits and about 1.2 million substance use visits in 2017. I will say this is the way it's classified. There are additional services when they're provided by a doctor, where the doctor maybe is prescribing the buprenorphine or is doing some other basic therapy. That's not, and here I'm talking about a primary care doctor, not a psychiatrist. That's not necessarily classified as a behavioral health visit per se. So those are the way that they're classified within those administrative systems. When we see sort of what's the productivity of the staff that's involved, we see on average there were around a little more than 900 mental health visits per FTE mental health provider, roughly similar, close to 900 visits per year, and substance use visits per substance use staffer. And so again, there are other contributions. The people who are the prescribers are typically speaking physicians, NPs, PAs, in some cases psychologists, but you know, mostly it's this. So most of the health worker that I'm talking about are really sort of counseling-related visits. When we do our multivariate regressions, basically what we see is that the National Health Service Corps staff have really made some important contributions, and they are somewhat more important in increasing treatment for depression and anxiety, particularly in rural areas. And in urban areas, the National Health Service Corps has been particularly important in supporting substance use treatment in urban areas. So the policy issue is there have continued to be efforts that have happened in the federal government. The federal government has made more investments in improving substance use and mental health services in health centers and other areas across the country, particularly in rural areas. The final point, however, I will say is we're stuck right now with so many things. The appropriations, people probably realize there's a continuing resolution that will end. And so what will happen with, you know, sort of the ability to continue funding for community health centers, for the National Service Corps, for some of those services is still somewhat up in the air. It's caught in the political gridlock that is part of our greater political system today. Thank you.
Good morning. As most of the panelists have mentioned, and part of the reason we're here is that in the United States, there's a large and growing rural disadvantage in health and mortality. Now, I promised my co-authors I wasn't going to do this, but I'm a demographer, and I want to give you a demographic context to this. I think it hasn't actually been mentioned. So, this rural disadvantage is unprecedented in human history. So for the vast majority of human history, urban areas were far deadlier than rural areas, far less healthy. And it wasn't until the turn of the 20th century that urban areas came to parity with rural areas. And it wasn't until the mid-1980s that rural areas started to fall behind, to show a disadvantage in health and mortality. So this is something to bear in mind. And virtually every year since the mid-1980s, it's gotten larger. So it's new, this rural disadvantage, and it's getting wider. And one of the important characteristics is that conditions related to mental health are disproportionate contributors to these. So there are particularly large differences in, say, suicide rates and rates of overdose and alcohol-related liver disorders that explain this rural disadvantage. So despite this, residents of rural areas use less mental health care than residents of urban areas, not more. So one explanation for this is that there's an access problem. We know that there are fewer mental health providers in rural areas than in urban areas. We know that rural residents are more often uninsured and poor. But there have been other explanations offered as well. Mental illness is perceived differently in rural areas. This is fairly well established. And this may make the rural residents more reticent to seek out and to use care. So to better understand this, we're going to focus on a fairly select group of people that need mental health services. So these are people that are identified as having a high level of psychological distress using two very well-known metrics, and who show a willingness to seek it out and to use it. We believe this is the first study to do it in a nationally representative sample. We're using the Medical Expenditure Panel Survey, and it covers the years 2010 through 2015. There. So there's my title. On to the first slide. So this first chart, it shows the annual average number of office visits per person. Those are the bars on the left. The average annual number of specialist visits. These are a subset of office visits on the right. And then the number of prescription drug fills. These are all for mental health. They're not any kind of use. They're for mental health. The dark blue bars represent urban dwellers, and the lighter blue bars non-metro. So non-metro dwellers. The lightest blue bar is our residents living in counties that are not in a metro area and are not adjacent to a metro area. So again, I want to emphasize that these are people that need mental health services. So you can see that even among this select group of people, the urban dwellers roughly have 3 times as many office visits as those in the most rural areas. They have almost 3 times as many specialist visits as those in the rural areas. You also see differences in prescription drug fills, but they are much smaller than the ambulatory care usage. So this is sort of the first hint that there may not be sort of an overall reticence to seek mental health care, but rather a heavier reliance on prescription drugs, pharmacological treatment than ambulatory care. So to get at that, I think it's important to point out that the standard of care really is both pharmacological and psychotherapy, not one or the other. So to get at that, we're going to look at an even more select group. These are people who actually filled a prescription drug for mental health. So these are people that need mental health care defined the same ways in the previous slide, and who have a prescription drug fill. So they show a willingness to seek out health care and use it. And you can see that even among the select group of people, there are still really large differences that residents in the most rural areas still use about half as many office visits as those in urban areas, and about half as many specialist visits. So since these differences are still large, even look at a very select group of people, and I want to note that these are adjusted for demographic and socioeconomic composition between the two areas, so they can't be due to differences in severity. These differences are large, and they suggest that really policymakers need to look at access, improve access, more than do education and outreach to raise awareness. And there's been some hints as to how to improve access, and I don't want to put too much emphasis on telehealth, telemental health, but for mental health, I think it's particularly well suited. There's evidence out there that remotely delivered psychotherapy is just as effective as in-person treatment. That's not true for all types of telehealth. So I think since I diverged at the beginning of my talk, I think I'll just stop there. Thank you.
Okay, I'm going to try to ask some fairly quick questions running down the row and then make sure we have some time for the audience. Hayley, I just want to play with the cause-effect issue here. You looked before and after closure. You looked at trends before and after. I realize there's no simple answer, but do you have a sense of how much the physician departure, you talked about it as a, actually I don't want to try to use the phrase used, but how much do you think it's foreshadowing or causing, I guess is the question, the loss of physicians prior to closure? Do you have any sense of that?
Great question. So by looking at physicians across specialties and actually doing the analysis where we were able to see the years prior to closure and post-closure and that variation by specialty, we do think that there is a critical, probably untangling to analyze this flight of general surgeons prior to hospital closure. But we also want to really emphasize how important the departure of primary care physicians is post-closure, especially up to like 8% in the 6 years after a hospital closure. That doesn't seem to be predicting the hospital closure.
That's very helpful. Thank you. Scott, you talked about the mismatch between what rural applicants are bringing and what medical schools are looking for. I don't want to put you on the spot. You work for the AAMC, but I couldn't help but feel that the mismatch has two sides, and it's sort of easy to think, what are these people bringing? But the other question is, what are the schools looking for? And what do we know about that side of the equation that might be part of the mismatch here?
Yeah, I appreciate the question and fully acknowledge. I think I chose the term mismatch because it is both sides intentionally, and there's much more to know about that than we looked at in this study. From the medical school standpoint, I think it's fairly well established that numeric quantitative elements of the application package tend to be ones that receive disproportionate attention. Many schools have increasingly adopted what are often called holistic admissions practices, where they try to look more comprehensively at what students bring. What is less clear is how overtly rural background is considered as one of those overt considerations. One of the things that we've done with a related study with the same group of co-authors is dive a little deeper, and this is a pretty wonky study, but looking at what AMCAS, the application service, puts forward to medical schools and opportunities to elevate the status of rural amongst those characteristics to allow those schools that choose to prioritize this to do so more effectively. And like anything, there's wide variation amongst schools. There are some schools that very explicitly in their mission focus on the rural workforce obligations that they feel for their state or their region, and others less so. So I think it's a matter of, when we look at the national picture with this study, the trends suggest that we need to think about this more carefully.
Thank you. Carrie, when you think about what you find from affiliation, it's a mixed picture. If you contrast this with closure, it's probably better. But I guess the question is there any other option, or does it, I realize this may go a little beyond the scope of the work you did, but I just wonder if open, affiliate, close, if we're thinking about this in sort of too structured a way, and if there are other options that might yield better results.
Well, one of the things that interests me about this question is that we normally think about healthcare consolidation as it relates to urban areas and high competition areas. And so what's interesting about rural areas is that, these are places where there probably wasn't very high competition to begin with. So I think it kind of goes back to Jan's points earlier about structural urbanism. And that ultimately market forces in rural healthcare are really challenging. And when you're running a hospital, whether you're for-profit or nonprofit, the margins have to work. And it's becoming more and more challenging in urban areas to do that. So short answer, I don't know. But definitely something for policymakers to think about and consider seriously.
That's great. So Leighton, you said no hard questions, so I'm going to ask a question of both Michael and you, and that way you've got a little buffer there. No. Leighton, I've known you for long enough to know you can handle hard questions. So my question here really is about and Carrie, I appreciate you bringing up the structural urbanism point. Both of you present some pretty positive trends. I'm trying to look for the levers. I'm trying to look for what's consistent about what is causing them to happen and how maybe we pull in some of the lessons from there to a broader discussion about the structural elements of building the right infrastructure. Because I can't quite pull those two together. I'm wondering if the two of you have thoughts about that.
If I understand the question, I guess it's really how do we take the results from our papers to sort of a policy implication for building a behavioral health workforce?
Yeah. Better said than I asked it. Thank you.
So I think I didn't go as far as saying this at the end of my talk, but I think that our results are an argument for expanding scope of practice, particularly in areas where behavioral health access is an issue, particularly addiction treatment, which is basically most areas. That is a very controversial and much debated issue at the state level, and I don't know to what extent kind of presenting data like this would kind of move the position of the controversy, but I think NPs and PAs are really, they are the ones replacing doctors who are leaving. There's evidence very clearly showing that they're the ones who are filling that gap. And so every way that we can not be necessarily so physician-centric. There are many different types of providers that can provide care that is needed, but they don't all have to be expensive MDs who are extremely hard to locate in rural areas. Even if you pay MDs a lot of money, they still will try to set up camp in whatever urban area they trained.
I'd agree with what Michael said, that part of it is recognizing that we do need, particularly in rural areas, though I think in the case of community health centers, we're also talking in urban underserved areas, there's a need to understand that it can't all be done through physicians, and part of what is important in understanding what the community health center model is trying to use non-physician staff, and they often say the phrase is at the top of their license. And so there needs to be that, and that has continued to be done. And then part of it is also, and I'll say I think both in the case of buprenorphine and behavioral health care services in general, there has been a long-term awareness that this was a real gap. I mean, I remember being taught years ago that the typical way we thought about health insurance and healthcare in the U.S. was it began from the neck down, and that things like mental health services, dental, vision services just weren't part of the picture at all. And that we realized belatedly that, what do you know, there are some things that need to be dealt with from the head up, and so there's been greater attention to that. We may be a little slow in beginning this effort, but hopefully slow is better than never.
Just wanted to add one brief thing, which is at least focusing on the NP and PA side of things, it's not settling for less. I think there's a really broad literature showing that NPs and PAs are really able to provide quality of care that is equivalent to MDs in many settings, and we don't have the data for this particular setting for addiction treatment, but I think we're really not necessarily losing anything in terms of quality care. It's just a different set of providers.
Yeah, so that's a great transition to what I was going to ask of James, and I appreciate you, even if your co-authors didn't want you to talk about going back to the transition from the turn of the 20th century through. But my question really is the follow-on to these last two, which is, you mentioned telehealth. We've also have a shift in provider training and who's providing services. Is there any evidence to suggest, because you began by saying that part of the lower level of use may be associated, I don't know if you said the word stigma, but I wrote the word stigma, and perceptions of care. Is it possible that do we have evidence that these other modalities of care, either different types of providers or telehealth, not just are effective, but maybe are less stigmatized or have more of a perception of being appropriate to use?
I didn't use the word stigma, but I meant it. So That's what I was talking about. Yeah, there is. There's a growing amount of evidence that shows that the telemental health, if you want to call it that, is just as effective as in-person office-based. There's even some evidence to say that it is better, that it's more effective, and this could be, so the reasoning goes that it does enable people to sort of seek care without being stigmatized. There are some barriers to that, though. I mean, like broadband is one of them, of course, and then there's payment barriers. While insurers have to reimburse remote telemedicine at the same level as in-office care, Medicare, for example, requires that care, even remote care, to be at an affiliated center. So that may be a problem. That may sell short the tool. So yeah, there is evidence that it works. I think mental health is a particularly good application of telehealth. I mean, particularly promising.
Okay, I want to bring in a few others to this conversation. I'll start here if we can get the microphone. And yes.
Hi, I'm Dr. Caroline Poplin. I'm a primary care physician. There's another intellectual area where rural-urban is talked about a lot, and that's politics. It's now becoming clear, or it's happening now, that rural areas are breaking away from suburban and urban areas politically. And it's thought in some situations, maybe in state legislatures, that rural areas have a disproportionate political impact relative to urban areas. And I was wondering if you'd factored that in or thought about looking at it or think that it matters.
Not sure how that would fit into the analyses you all have done, but it's a good question.
So in our analysis, when we look at the map of rural hospital closures and we think about this partisan divide with Medicaid expansion, we see many rural hospital closures concentrating in states that did not expand Medicaid, and uncompensated care could explain a number of rural hospital closures. So that is one point where we can look at that partisan political divide.
Okay, that's good. Yes, over here. Sorry. I know that the lights make it hard for me sometimes to see, so be persistent.
I understand. Gwen Darien, Patient Advocate Foundation, National Patient Advocate Foundation. So I wanted to, there were a number of issues in terms of the pipeline and in terms of having enough rural health practitioners that were in both panels, and I wanted to see if we could, if you could weave through some of these issues. So one of the things that came. Pardon me?
Let's weave quickly, okay?
Let's weave quickly. Students from rural areas are more likely to practice in rural areas. There's a mismatch between what medical schools are looking for, and healthcare should match community need. So how do you weave those together so that you ensure that there is not this mismatch, and that what medical schools are looking for or what training is looking for meets the needs of the communities and trains people who will stay in those communities?
That's great.
So I think that you point to a really important additional benefit of training a workforce that reflects the society which it should serve, and that is that not only does growing up in a rural community increase the likelihood of practicing there, it also increases the likelihood that wherever you practice, you have a better understanding of rural populations and their health needs and their lives. that fundamentally matters in providing care. So if you're a specialist in an urban area but grew up in a rural area, when patients come to you from rural areas, you have a different level of understanding. If you grew up in a rural area and you're training with people who haven't lived in rural areas, you're imparting that perspective in a way to others. It reflects, I think, or parallels in many respects the same arguments for diversity that are well established and highly valued around racial and ethnic diversity. I think the same can apply for rural. It just hasn't necessarily raised to the same level of awareness, and I think the trends going in the direction they are should be a call to action for raising the awareness of that.
Can I add something quickly? So there is sort of this awareness that medical schools and also residency programs that are typically based out of academic medical centers are highly urban biased, and then in addition, they're hospital centric. I mean, just the nature of this. And so there's become a movement to try to sort of shift some of these practices back towards ambulatory care, back towards service in underserved areas, whether we're talking about urban areas or rural areas. So this is one of these things that can be encouraged. I mean, at GW, we have something called the Beyond Flexner movement, part of which has to do with trying to say, gee, really shouldn't be the purpose of medical schools and academic medical centers to create practitioners who will actually serve people where they live and where they need it, as opposed to trying to do things that, I'm sad to say, are really sort of favoring sort of what the pet projects of the medical faculty are.
Yeah, if I could just make one last comment on that, I think that's very important, that it's not just who we're bringing in, it's what we're exposing them to during training. If we want to really move the needle, I'll be the third person to reference that, in terms of this long-standing problem we've had with adequate rural workforce, it's both. It's having people who know what it's like to live in rural communities, and it's knowing what it's like to practice in rural communities, and the only way you can know that is to experience that during training.
Back here, yes.
Bill Vennerfrock with the National Association of Rural Health Clinics. One, I have to say at the outset, I was disappointed that I didn't hear anybody mention rural health clinics as part of the solution or what it's being done there to address some of the issues you've raised. But Dr. Bennett, I did want to point out that you made the reference to increasing utilization of PAs and NPs with regard to buprenorphine. We're seeing and I suspect that many of those rural NPs and PAs are working in rural health clinics. One of the things we've seen just recently is that CMS, when you talk about barriers, rural health clinics are required to have 51% of their services are primary care. They're not classifying these services as primary care. So we've had several rural health clinics that have been threatened with losing their rural health clinic designation because they're doing too much in the way of substance use treatment. And so I think that's one of the issues we need to address. In terms of a question, I was struck by the fact that the first speaker spoke exclusively about physician impact on hospital closure, but there was no acknowledgement of what others have referenced, which is there are a whole range of other providers who are out there in rural underserved areas delivering care. And so is it a problem that we're losing physicians if we're able to replace them with other individuals who are equally capable of providing care in those communities?
So as a nurse, I at first wanted to look at the impact of rural hospital closures on both the registered nurse workforce and the nurse practitioner workforce. Unfortunately, we simply haven't started collecting that data until like the past 6 years. So maybe 6 years from now, we can start evaluating more of the consequences, but we're really strapped for what we understand, given what we know.
That's pretty striking. Yes.
I just wanted to say one quick thing about the rural health center designation. I guess we talked a little bit about stigma earlier. I think the policy around buprenorphine prescribing and substance use treatment in general is rife with stigma that's anachronistic, and I see kind of a really disappointingly low amount of policy attention given how easy some of these things are to fix, right? That's really not a hard fix. But I think, how can we better get the attention of state and federal legislators to actually, do relatively win-win situations that can just help health and people get better.
So I'm trying to, again, make sure I'm not missing people with the lights. Okay. Yep. We'll take one last one here.
Hi, my name's Shira Rosenfeld. I'm with the Parkinson's Foundation, and thank you all for your presentations today. It's really interesting. So my question, and maybe I'll hear this more in the health outcomes session, but I did not hear much conversation about chronic diseases, people with chronic diseases, and how that plays out. And of course, I guess there's a part of me that says, all right, things are really difficult, so, and there are real challenges for just your average person with healthcare needs in a rural community. So if you're an individual who has a chronic disease like Parkinson's, for example, where you do need people who have specialized skills, does that just mean that everything is sort of magnified and multiplied in terms of the challenges and the issues? But I would love it, and again, maybe folks in the last session will have more to comment, but if any of you have any particular, if you looked at that in your work, if there's more on that in the articles, any perspective that you could share.
So there definitely is more of that coming later, but I don't want to cut off anyone here who has thoughts about it. Mike.
I guess I have one small thing. I guess it's kind of maybe just a reflection based on some of my other research. So I do a lot of work in telemedicine, particularly around mental health. And I think just one thing which is not addressing that issue is that I think actually telemedicine, also in rural areas, is really dominated by telemental health, and there are many reasons for that. But the idea that we are going to fill this gap, say for neurology access, with telehealth, doesn't really, the marketplace is not really responding in a meaningful way that we can find. It's very minimal use. So I think that's just one potential myth out there, that telehealth is being used for this highly specialized medical specialty care, and it's not what we see. So maybe, and is that something to be alleviated, or is it the market saying there isn't much demand for it?
So we have a lot more to cover around insurance and then some of the outcomes, which will tie also to the utilization question just asked. We're going to take a 15-minute break, but please join me first in thanking our panelists. Yeah, we got it. Great. Okay, thank you all for coming back so quickly. I just want to make sure we have time to get through all of the content we have. We have two papers looking at insurance premiums, and then we'll move to a closing panel that tackles the topic of health outcomes from quite a variety of dimensions. In this panel, which is no longer the break, we will be hearing from David Anderson, Research Associate in the Health Policy Evidence Hub at the Margolis Center for Health Policy at Duke University, and from Abigail Barker, Research Professor at the Brown School of Social Work, affiliated with the Center for Health Economics and Policy at the Institute for Public Health at Washington University. And I'll turn it first to David.
Yep. Thank you very much. I have the joy of presenting a fairly happy story, which is a good little break. I also want to thank my wonderful co-authors. I'm Coleman Drake of the University of Pittsburgh and Gene Abraham of the University of Minnesota. And what we wanted to do with this paper is look at affordability on the Affordable Care Act before and after cost-sharing reduction subsidies payments were terminated. Benefits were still continued, but the payments were terminated in the fall of 2017. Before I really get started, I really need to talk about the mechanics of how subsidies are calculated in the Affordable Care Act. There are two groups of people that we need to be concerned about. Sorry. Which button do I press? The first group are individuals who earn over 400% of the federal poverty level, so approximately $50,000 for a single individual in 2019. These individuals receive no federal help. They pay full cost of care for their premiums. The other group are individuals who are subsidized. These individuals earn between 100 and 400% of the federal poverty level, and they receive a premium tax credit which pays for the gap between the expected contribution and the benchmark plan, which is a silver plan. We'll talk about that in a second. There's a small group of folks who earn between 100 and 250% of the federal poverty line who receive a second set of assistance from the federal government. That's cost-sharing reduction subsidies. These subsidies reduce your out-of-pocket costs, so lowers your deductible, lowers your co-pays, lowers your co-insurance. We wanted to look at affordability, and we defined affordability as the least expensive plan after any subsidy that was available to you. For a 50-year-old single individual who is a non-smoker earning 400% of federal poverty level, and 401% federal poverty level. Thank you. 401% is the lowest premium level, lowest income level where you receive no assistance. 400 is highest premium, highest income level where you received assistance. And we have two different stories to tell. The first is the unsubsidized story. Premiums are going up, up, up. Rural premiums are a little bit higher than urban premiums, but they're paying full freight and they're paying through the nose. This is not a good story. There's a lot of policy tension, which we'll talk about in a couple slides. 2014 through 2017, subsidized individuals, their least expensive premium at 400% of federal poverty level is pretty flat. A little bit of wiggle room, a little bit of noise, but it's pretty flat. Rural premiums are slightly more expensive than urban premiums, but there's not a whole lot going on here. However, in 2018, huge drop. Rural premiums for the least expensive plan became much less expensive, net of subsidy for subsidized individuals, for rural individuals compared to urban individuals, but for all subsidized individuals, premiums dropped dramatically. So what happened? Silver loading happened. Cost share reduction subsidies were never effectively appropriated by Congress. It was an oversight in the drafting of the law. In October 2017, the Justice Department determined that no, they should not make any further appropriations. However, insurance companies were still obligated to pay to provide this benefit, and insurers will make sure that they get paid for the services that they render. So they had three choices. One, they could do nothing. Two, they could broad load, which is put the cost of the CSR subsidies into every plan. In 2018, 5 states did that, Colorado and Delaware, as well as Indiana, West Virginia, and Mississippi, which those 3 states did that in 2019 and 2020. And then everyone else adapted strategies called silver loading, which put all the costs into all the silver plans, which sets the benchmark, or silver switching, which puts all of the costs into only benchmark and subsidy eligible silver plans, which further boosts the benchmark. So what this means on a pragmatic basis is that the benchmark went up much faster, the benchmark premiums went up much faster than the premiums of all other plans. And since the subsidy is based upon, excuse me for a second, sorry. And since the subsidy is based upon the gap between your expected individual contribution and the benchmark level, the subsidy got a whole lot bigger. So what does this actually mean? Premiums dropped dramatically for subsidized individuals. $191 on average for a rural individual in a subsidized market if the state silver loaded. $125, $126 for an urban individual. Silver switching, even bigger gains. Broad loading, small gains. Monopoly is a bad thing for unsubsidized individuals. It's an okay thing for subsidized individuals. This is very counterintuitive. Monopoly is good. No. High premium levels are good. Yeah. So we need to think about affordability in the context of the ACA. Affordability is key. We assume, with amazingly good evidence, that when things are less expensive for payment out of pocket, people buy more of it. People buy more insurance, they buy more Tootsie Rolls, they buy more of everything. Subsidized buyers are sensitive to the premium spreads between the premium level of the plan that they want to buy and the benchmark point. Bigger the spread, more affordable things are. Non-subsidized buyers care more about the premium levels. They just care about what the absolute price is. So when we think about affordability in the ACA context, we need to think about whose affordability. We are currently in a policy environment, intentional or incidental, that has dramatically increased affordability for subsidized buyers, especially in rural areas, over the past 2 years compared to the first 4 years of the ACA enactment. Now, this is because the CSR payment termination dramatically increased the premium spreads. As we go forward, we need to consider whose affordability needs to be addressed, and the actions on 1332 reinsurance waivers and parallel markets seem to be addressing affordability for non-subsidized buyers, and those actions will probably have more affordability impact in rural areas and urban areas just because the premium levels are currently higher. Thank you very much.
Thank you. I'd also like to acknowledge that I'm also affiliated with the Rupri Center for Health Policy Analysis, and it's under that heading that I've actually been doing this work. And I'd also like to preface what I'm going to say by sort of asking you to remember Jan's remarks at the beginning about whether tweaks are actually the way to go in addressing some of these policy issues. This analysis is really kind of based upon the idea that I'm working with what we've got, and we can tweak this essentially market-based model, but it may not fundamentally be the right approach. But that being said, that's what I'm going to talk about now. So prior work, So prior work in market-based insurance, thinking about Medicare Advantage, thinking about health insurance marketplaces under the ACA, and also thinking about the Federal Employees Health Benefits Program, have often shown that premiums are higher in rural areas, as David's slides showed too. And in particular, the data set I had access to and wanted to look at was the Federal Employees Health Benefits Program data, on which actually the ACA marketplaces were designed and developed on that model. They have national plans and state-specific plans. My analysis focuses on the state-specific because they're the ones who act at a regional level. So they set their service area regionally and their pricing regionally, and so that's more relevant for rural. Also, the concentration of enrollment is not necessarily directly correlated to population size because it's for federal employees. And so that also helps to identify some of the, in my multivariate analysis, it's helpful in identifying the differences between enrollment and just overall population size and density. So there's anecdotal evidence that's out there that says lack of healthcare providers is one of the things that causes premiums to have to be higher. This is put forth often by insurers who say that network adequacy compliance is a factor that sometimes gives rural providers leverage to ask for higher rates. And so that's kind of the motivation for why I wanted to look at this question, to try to sort of separate out the different competing explanations. So just to get to the results, what I found was that actually the number of covered lives was the most important thing in predicting premium variation. Now, I did have a time series data set, so I controlled over time. I will also acknowledge there was a lot of persistence over the time period that basically said that to a large extent what we see in 2013, say, is predictive very much of what we're going to see in 2016, just because of structural forces in the market that don't change very much over time, including competition. That being said, I found that each additional enrollee reduces premiums, and this is a biweekly premium, so you have to multiply it by 26 or something to think about the year, 10 cents per person, which doesn't sound like a lot, but it's actually really a pretty large amount for each additional person being enrolled to have that kind of impact on the average premium per person. And that was the rural result, whereas in urban areas, the number was trivially tiny. So I thought that was, the model controlled for a number of other things. It controlled for providers, levels of providers, provider density, both with respect to other people. So in other words, providers per population, which helps kind of control for this issue of scale. And then also providers per land area, per square mile, which helps control for this idea of providers spread over space and how that looks in terms of network adequacy standards being a driving factor. So I think this makes a lot of sense because fundamentally, insurance is about spreading risk, and it relies upon having a large number of people in a given risk pool in order to work well. So the policy implications, I think, for this are to try to eliminate this problem of small risk pools, either by having larger risk pools, ideally, but then you run into the problem of whether you've defined an area that's too big to be a good geographic size for network adequacy purposes, or you can think about risk reinsurance, and that's something that was in the ACA, but it wasn't really, didn't really play out the way that it was written in the ACA. I think emphasizing that a little bit more would be helpful. This is insurance for the insurer and kind of mitigates the problem of small risk pools. And although I didn't find this notion of network adequacy to be a driving factor in explaining premium variation, that doesn't mean it's not an issue at all, because there are a lot of places where insurers don't even participate in a rural county or in a rural area, and that could very well be explained by a lack of providers. And so just to wrap up and again to talk about this having more broad implications for this market-based, market-driven model of health insurance provision, I think in order for markets to work well, you need to have these provider shortage issues addressed, in addition to the other policy implication that I just mentioned of risk reinsurance. Thank you.
Okay, I will also start with a couple of questions. David, you did a terrific job of describing a complicated hydraulic. I wonder if you could take the provider side of this, since one question is how many dollars flow into the health sector to support providers. What's the relationship between the changes you describe and the actual outflows to the providers, to the healthcare system?
That is an absolutely wonderful question, and I do not have an immediate answer for that. For the 2019 plan year, approximately $79 billion in federal spending was used to subsidize the ACA through advanced premium tax credits, of which that probably supports slightly more than $100 billion worth of total premium, of which at about an 82-83% MLR, we're looking at $82 to $83 billion worth of actual medical claims. Due to the cost sharing reduction subsidies, CBO projected that would cost approximately $10 billion additional dollars this year, so minus everything I said by about $10 billion as the increment. And there's some wonderful work recently in the Health Affairs blog by CBPP, I believe, where they estimate about 500,000 additional individuals were covered, which conforms to CBO estimates as well, due to this hydraulic.
So I actually think I meant to ask a simpler question than you thought I was asking, but maybe not. So when premiums go down, given the dynamics of silver loading, the fact that the observed premium to someone receiving a subsidy goes down, that does not reflect a decrease in resources going out to provide health care.
That's a much simpler question. So yes.
Yeah. Sorry.
Correct. There's no change to actual healthcare resources available to a county. If anything, it slightly increases as more people are buying insurance.
That's what I was trying to make sure I got
Sorry
right.
about that.
No. My bad in not framing the question well. So this brings, Abigail, I want to bring you in, but David also, this question of the size of the risk pool and the size of the rating areas. And it does, you alluded to it quickly, the notion that you could increase the pool size by increasing the rating areas. Doesn't seem like you would have to have uniform network adequacy standards if you expanded it. What do either of you have from the data you've worked with to suggest the potential merits and demerits of requiring or encouraging or considering increasing the geographic areas of the rating pools?
Do you want to take this one first?
Sure. So we had previous work, actually also published in Health Affairs several years ago, that just looking at FEHBP, and then I can talk about marketplaces too, that found that actually the best thing in terms of controlling premiums in rural areas was to focus actually on the nationwide plans. I mean, the nationwide plan in FEHBP is Blue Cross Blue Shield for the most part. And because they had that nationwide community rating, their premiums were actually lower. And so for a rural place, that can actually be helpful. And so I think I would say that in a lot of other work we've done in marketplaces as well, to the extent that it's reasonable and feasible, the bigger the rating area, the better. I would probably encourage each state to just have a uniform rating area across each state. Some of the smaller states have done that. Of course, I don't see, there's no real reason, as you said, there's no reason why that has to be the same as the service area necessarily, but you could have additional regulations on that as well.
Great.
I have nothing to add.
Okay. A couple of questions we can squeeze in here. This is technical stuff. Don't worry about embarrassing yourself. So technical, you're still absorbing it.
Over here.
Oh, sorry. Again, it's hard sometimes to see with the lights. We'll take a question.
Hi, Jessica Schubel from the Center on Budget and Policy Priorities. I've written a couple of pieces on how Medicaid makes the marketplace work better in terms of lowering premiums. And I was just curious, this question's for David. And when you looked at the differential between rural and urban premiums, did you see any difference in terms of the Medicaid expansion, non-expansion state breakout in your study?
Thank you for the question. Yes, we did. Our results on urban and rural, it was more important on subsidized versus unsubsidized than rural versus urban. We found that premiums for subsidized individuals were higher. For states where there was Medicaid expansion, because the risk pool was much healthier, this conforms to work that Adisa and Tom DeLaire have done. And at the same time, on average, premiums were lower for the unsubsidized because, again, the risk pool is much healthier. This brings back to the final point of whose affordability do we want to prioritize. So Medicaid expansion is wonderful for non-subsidized affordability, but not as good for subsidized affordability. But that brings us in the question of the quality of medical care for the individuals who are Medicaid expansion eligible as well. So it's a very complex moral and technical question.
That's great. Okay, well, these are great contributions to our understanding and the complexity, and I'm glad, Abigail, at the outset you tied it back to the sort of question of systemic versus incremental, and these certainly are good analyses that show us the implications of modifications within the system that we have. You look like you're
I guess
wanting to
I'll
add
say,
something.
since there are no other questions, I'll just tack on to that and say that I think that, like, from an economics point of view, and actually, like, environmental economists talk about existence value and how do you price the value of existence of something, and I think that that really applies here too as well. That in some cases there's existence value to a resource just being there, and payment models should adjust to reflect that. And part of the initial germination of this work is trying to sort of figure out, and of course the data is always really limited in what you can make it tell you, but to try to understand a little bit better these different cost structures and how because there's low volume, there's higher fixed costs essentially and lower variable costs in rural places. And so how do we understand what the shape of those cost curves looks like so that we can change the payment policies to track with that.
Great. Okay, thank you very much. Oh, okay, we can squeeze one in. Sorry, I thought.
Oh, you want to hear me?
Oh.
You're there.
All right, well, I'm here. So.
Carl, you got the mics.
Possession is 90%. So a lot of care is delivered both in the exchange and Medicaid through HMOs to low-income populations. Do we know, or do you know of any studies for your own research about how these HMOs, and when they deliver this care in urban versus rural areas, if it's different in terms of how they organize the care, how many resources they provide, and whether the scarcity of care that's experienced by the populations is similar or different?
That is an absolutely wonderful question, and at this point, no, I don't know that directly. It would be a wonderful thing to read. We have some preliminary research for future manuscripts that looks at quality care as measured by CMS by insurer attributes, and Medicaid managed care organizations do look like which tend to be HMOs, do look like they have a very differential quality profile than other organizations, including the Blues and nonprofit insurers, but I can't say much more than that this time.
We actually have a project underway this year with the Rotary Center that is looking at the impact on rural populations of the geographic extension of MCOs into rural places over the past 2012 through 2018, I think is our time frame, because there have been 23 states over that time frame that have extended the managed care portion of their Medicaid into more rural places. And so we may be able to answer some of those questions and, look for us to have a product sometime in summer of 2020.
Okay, I'm afraid we are going to have to leave it there because we got one more panel, but please join me in thanking our panelists here. And we'll get the name. You all are free to go. We'll get the name tents up for our last group. Free to go. That's a nice way of saying get out of here. Okay. All right, you're not going to want to miss the last panel, which is going to focus on health outcomes. Can I get our panelists to start making their way up here? And as they take their seats, I will, come on, don't be shy. Yep, oh, that's true. I guess you have to know where to sit. That's fair. Okay. Now that they're on their way up, we'll be hearing from Kenton Johnston, assistant professor in the Department of Health Management and Policy at the St. Louis University College for Public Health and Social Justice, from Scott Phillips, editor and researcher at the F. Marie Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center in Lubbock, Carrie Henning-Smith, assistant professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, Sirin Yaemsiri, a senior statistician at the U.S. Government Accountability Office, Jan Probst, who you have met already, distinguished professor emeriti at University of South Carolina, Katy Kozhimannil, director of the University of Minnesota Rural Health Research Center and associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. I'll turn it over first to Kenton. Let's get your... There we go.
Hi, everyone. I'm Kenton Johnston. I want to start by acknowledging my wonderful collaborators on this, Hefe Nguyen and Karen Joint-Maddox. The title of my presentation is Why Do Rural Medicare Beneficiaries Have Higher Rates of Preventable Hospitalization and Mortality? So the first place to start is with the prior research on health outcomes, and we've discussed that a lot this morning, that prior research is pretty conclusive that rural Americans have poorer health outcomes than their urban peers. Especially over the last 30 years, there's been a growing gap in mortality rates, with rural areas seeing greater mortality than urban areas. There are more hospitalizations and emergency department visits for rural residents, and this is especially true for patients with chronic conditions. And so that's the focus of our study. In our study, we looked at Medicare beneficiaries who had one of 5 complex chronic conditions, and those were heart failure, ischemic heart disease, diabetes, COPD, and asthma. And so what we found looking at these people with similar conditions, we also, I should note, defined rural versus urban using county classification with the CBSA codes. And so we have rural, which you could roughly translate as remote areas less than 10,000 population, micropolitan, which would kind of be like towns, and then metropolitan, which would be what we would think of as urban areas. And we found 40% greater rates of preventable hospitalization in rural compared to urban areas. And we also found higher mortality rates, 23% higher mortality rates in rural areas. And remember, these are people with the same chronic conditions. And so CMS is well aware of these health outcome disparities, and recently released about a year ago a rural health strategy that seems largely to focus on initiatives to expand access and supply. So talking about things such as expanding the scope of practice of non-physician providers to increase primary care services, expand access to telehealth and virtual services, including things like remote evaluation of patient information, and then also increasing the wage index of rural hospitals to help enable them to compete better for staff. And so that begs the question of what the physician supply rate actually is in rural versus urban areas. And so this is one of the things that I actually found surprising in this study. When we looked at the supply of primary care physicians and specialist physicians, we actually, by hospital service area, so this is data coming from the Dartmouth Institute, we found that there's really not much difference in the supply of primary care physicians between rural and urban areas. Rather, it's in the area of specialist physicians in particular where we found a 31% lower rate of supply of specialist physicians in rural compared to urban areas. And so I'm from St. Louis, Missouri, so I thought we would take a look at, zoom in on a map of some flyover country here and look at the local hospital service area primary care supply rates in Missouri. And the darker areas are where there's greater supply, lighter areas are where there's less supply. And as you can see, you don't see the darker areas clustered around the major urban centers, so around St. Louis, Kansas City, Columbia, so much in Missouri. There's not a discernible pattern where you see higher supply of primary care doctors in urban areas. However, when we look at the supply of specialists, you can see there is more of a cluster of higher supply in the St. Louis, Columbia, where the State University is, and the Kansas City areas. And so supply of physicians is one thing. The next question is, what about actual contact with or access to those physicians? So going back to our Medicare data with the chronically ill, we found that there was a very similar rate of contact, of having one or more primary care visit between rural and urban beneficiaries. On the other hand, there were about an 8% lower rate of contact with specialist physicians in rural areas and an 8% lower rate of contact with both primary care and specialist physicians. And remember, these are chronically ill people who you could argue probably should be visiting both a primary care doctor and a specialist once a year. So the next question is, well, what effect does this really have on outcomes? And so at this point in our study, we did some regression analysis. We were really interested in what is the effect of seeing both a primary care doctor and a specialist on these outcomes. We controlled for demographics, clinical comorbidities, functional status, and social risk factors. And what we found is that seeing a specialist annually, in addition to seeing a primary care doctor, was associated with a 15.5% lower incidence rate of preventable hospitalizations and a 16.7% lower odds of mortality. And these are among all Medicare beneficiaries, both rural and urban beneficiaries. So the next question is, does this effect that we see perhaps explain some of the gap in rural-urban mortality and preventable hospitalization rates? So we did a decomposition analysis. I won't bore you with the details. You can read the paper for that. And really what we were trying to say is, to what extent do demographics, medical comorbidities, functional status, social risk factors, and access to care explain this disparity? And we found that the biggest explanatory factor was with access to care. And in particular, the single variable that had the greatest explanatory factor was the local area supply of medical specialists. That explained 55% of the difference in preventable hospitalization rates and 40% of the difference in mortality rates. And so as a result, we conclude that really it's lack of access to regular specialty care in rural America that appears to be a primary driver of higher rural hospitalization and mortality rates for the chronically ill. As a result, we would recommend CMS to consider focus on expanding access to specialty care in rural areas. It could be virtually through telehealth initiatives or physically via partnerships with urban health systems. I know in the St. Louis area, one of the health systems has a partnership with kind of extenders in rural areas where they send specialists out kind of on an intermittent basis in rural areas to treat people. With that, I want to thank you for listening, and I look forward to the discussion.
All right. Hi, everybody. My name is Scott Phillips, and I'm one of the co-authors of our paper. It's called Higher U.S. Rural Mortality Rates Linked to Socioeconomic Status, Physician Shortages, and Lack of Health Insurance. And this was done by our research team at the F. Murray Hall Institute for Rural and Community Health at the Texas Tech University Health Science Center. Let me also preface this by saying our primary author is Dr. Gordon Gong. He recently retired, so let me echo Dr. Ku's plea for mercy. And when it comes to statistical questions? Thanks. All right, let's start. All right, we've seen a lot of this today, but this is a good way to visualize it on why focus on rural mortality. Since the 1980s, all-cause mortality rates in rural America have exceeded those in urban areas. And the gap between rural and urban mortality rates has continued to widen. You can see it just getting farther and farther apart, and that includes, this goes up to 2015. Doesn't really even talk about how both are starting to increase, but the gap continues. All right, let's start with this map. This gives a sense of what this study does. We're looking at state-level mortality using rural-urban continuum codes. This is the urban rate. And you get a pretty good sense here of the darker the color, the higher the mortality rate in America. And you see down from Ohio all the way to the deep south and bleeding over into Oklahoma, that's where the higher mortality rate is. And that darkest of dark colors is in West Virginia, the highest urban mortality. The transition to rural, as you're about to see, is quite stark. Same color coding. The disparities go up considerably between urban and rural for most of the country. In fact, only 3 states don't have higher rural mortality than urban mortality. And that's an interesting question and a discussion for another day because there are 3 contiguous states in the Mountain West: Montana, Wyoming, and Colorado. Every other state, rural mortality is higher. And let me point out a couple of things here. Hawaii, Connecticut, and Colorado have the lowest mortality rates in rural areas, while Kentucky, Mississippi, and Alabama have the highest. And Kentucky was 164% the level of mortality of Hawaii. Urban was almost the same percentage difference. West Virginia was the highest, and it was 169% of Hawaii. Hawaii, if there's any moral to take away today, move to Hawaii. All right. So the question is why and what can we do about it? We looked at 5 explanatory variables for rural-urban disparities. All right. Socioeconomic deprivation, the percentage of the uninsured, the primary care physician supply, the percentage of racial and ethnic groups, and rural-urban residents. The first one might need a little explanation. What is socioeconomic status? Instead of just focusing on poverty alone, we need something a little more well-rounded. So we used a thing called the Albrecht Wellbeing Index, which looks at the household poverty level, but also includes things like adequate housing, employment, education, okay? And let's see the results. This is what we ended up with. See, that number is 81.8% of the total variance in mortality between urban and rural, both within states and rural versus rural between states, urban versus urban between states, can be accounted for these top 3 factors combined: socioeconomic deprivation, the uninsured rate, and the primary care physician supply. You notice that 2 of our guesses got knocked off there. The percentage of racial ethnic groups and rural urban residents. And the reasons why are fascinating and tell us almost as much as the first 3 tell us. Let's look at what we knocked off here. Our findings indicate that the percentage of African Americans is positively associated with mortality. However, after adjustment for socioeconomic deprivation with the other covariates in the general linear model, the percentage of African Americans is no longer significantly associated with mortality. That's fascinating. Let me be clear here that that's not to say that African American mortality isn't the highest in the nation. It definitely is. What the analysis reveals, however, is that other disparities African Americans also face account for this problem. All right. And running short on time, but interesting, you see it more about it in the paper, is that the Hispanic Americans have a negative association with mortality, and that's due to the Hispanic paradox. And it's an interesting whole other discussion. Finally, rural-urban residents. We didn't expect this, and it's interesting, at least at the state level, rural residents in and of itself does not appear to negatively affect mortality. After we adjusted for covariates, it indicates that rural residents tends to favor lower, not higher mortality. That is, our state level findings suggest that rural dwellers would have lived longer than their urban counterparts had their socioeconomic conditions and access to care been similar. That's fascinating. Finally, policies. We're about out of time, and a lot of these have been discussed today, but we should point out that these are all economic problems, and these economic problems often have policy solutions at both the federal and the state level, and that's why we focus on the state level things. Medicaid expansion has been discussed a lot today. That's an important part of this. Also, telemedicine and telehealth parity laws can make a big difference in the physician supply problems. And on the federal side, we need to remember federal programs that need to be adequately funded, like SHIP and FLEX. That's the Small Rural Hospital Improvement Program and the Medicare Rural Hospital Flexibility Program, and the HUD Hospital Mortgage Insurance. These all help critical access hospitals stay afloat. And that's it. Thank you.
Thank you. Thanks for having me today. My name is Carrie Henning-Smith. I'm an assistant professor at the University of Minnesota School of Public Health, and I want to acknowledge my co-authors on this paper, one of whom is on the panel here, and I also want to acknowledge our funders, the Federal Office of Rural Health Policy, for supporting this work. So if I'm going to leave you with one point today, I want it to be this one. So far, most of the papers that we've heard about have been excellent, and they have focused on rural-urban differences in all sorts of things. And rural-urban differences matter a lot, but so do within rural differences. Rural areas are not all the same. Rural people are not all the same. So if you only remember one thing from my talk, let it be this. And I think this map is a really nice illustration of that, and also a really nice reminder, if it hasn't already been said today, that rural areas are the vast majority of the land mass in the US. This is most of our country. It's not most of our population, but it's most of our country. This map shows us the county-level racial and ethnic composition among rural counties. Those gray counties are metropolitan counties. We're not looking at them here. The others are all rural counties, and they're shaded according to what group is the majority in their county. The light blue are majority non-Hispanic white. It's the vast majority of all rural counties, but it's changing. Rural areas have always been racially and ethnically diverse. They're increasingly racially and ethnically diverse, as we heard earlier today, due to immigration. And you can see the patterns of where people live, probably not in the back of the room, but these patterns have deep, deep historical, political, policy roots around where people are clustered. The orange counties in the Southwest are majority Hispanic counties or Latino. Those counties that are red, that tend to be clustered in the Southeast, are majority non-Hispanic Black. There are majority American Indian, Native American counties in green in the Southwest, in Alaska, and in the Great Plains. And we see those in the really dark blue here are counties with no majority group. That's a fast-growing group of counties. We're going to see more and more of those over time. And so these counties vary in their access to resources. They vary in the experience of life within these counties, and they vary for structural and policy reasons. This is just some example of that. We look to see if there were differences in socioeconomic status, some of the factors that we just heard about in the last presentation, and we found that those counties with a majority non-Hispanic Black, American Indian, Alaskan Native, and no majority group have significantly lower median incomes on average on the county level compared to their rural peers with a majority non-Hispanic white population. They also have higher unemployment rates compared to those counties with a majority non-Hispanic white. And then we looked at limited access to healthy foods. This is kind of a technical measure, but it's measuring of people who live beneath 200% of the federal poverty level, what percentage of those folks live more than 10 miles from a grocery store? There are all sorts of ways you can measure access to food. This is a pretty standard one. And we found that those counties with a majority American Indian or Alaskan Native population have more than 3 times the rate of limited access to healthy foods compared to their rural peers with a majority of non-Hispanic white. We also looked at differences that you can see in the paper on access to primary care physicians and on demographic characteristics, so gender composition and age composition in the county. And why does this matter? Matters for this reason. So here you can see in the, I don't know what color we're going to call that, bright blue, the darker blue on the left side. These are unadjusted differences in premature death. This is defined as years of potential life loss before the age of 75, if we expect people to generally live to about age 75. We're counting all those years that folks didn't make it to 75 per 100,000 people, and this is aggregated over a 3-year period. So the darker blue is the county level average, not adjusting for anything, but just looking at how these rates of premature death vary by the majority racial or ethnic group in the county. And you can see really striking, really appalling differences here, where those counties with a majority non-Hispanic Black, those counties with a majority American Indian and Alaskan Native, and those counties with no majority group have significantly higher rates of premature death compared with counties with a majority non-Hispanic white population. We, in other work, have looked to see how these groups compare with their urban peers with similar racial and ethnic composition, and every rural county does worse than every urban county, even within their similarly grouped racial and ethnic peers. But this is just within rural counties. And then to Dr. Bennett's point earlier this morning about how as researchers, we want to be able to account for all of this. We want to see what explains it so that we can do something about it. And so that's what we tried to do. Those lighter blue lines are showing after we adjusted for socioeconomic status, for primary care physicians, for demographic characteristics at the county level, did those differences go away? And they did for every group except the group with the majority American Indian, Alaskan Native folks. The difference between that group and the group of non-Hispanic white remains significant. This tells us we need policies that address social determinants of health, but we also need to go beyond that to address structural racism, historical trauma, discriminatory policy. I could talk a lot longer about this, and I hope we'll have a little chance in the Q&A to talk about it, but I'm going to leave you with that for now, and thank you for your time today.
Good morning. My name is Sirin Yaemsiri. I'm a senior statistician at the U.S. Government Accountability Office. I'd like to start by acknowledging the research team. I'm delighted to be here on behalf of the team. We evaluated urban and rural progress towards meeting national targets for 7 major causes of death in Healthy People 2020. Our key findings were that rural areas had higher death rates than urban areas for all 7 major causes of death, and that rural areas had not met any of the Healthy People 2020 national targets. So I'm going to give an introduction on Healthy People 2020, our data and methods, before going into the findings in more detail. Healthy People 2020 is a federal initiative led by the Department of Health and Human Services. It includes hundreds of measures that provide a framework for measuring public health priorities. A key feature of Healthy People is that it has national targets for each measure, and the goal of Healthy People is to reach the target by the end of the decade. Our data are from the 2007 through 2017 National Vital Statistics System collected by the National Center for Health Statistics. These are the official statistics for deaths in the United States. We examined rural and urban progress for the 7 major causes of death listed on the right. And these included cancer, chronic obstructive pulmonary disease, COPD, coronary heart disease, CHD, diabetes-related deaths, unintentional injury, stroke, and suicide. We examined age-adjusted rates for these 7 major causes of death, progress toward target attainment, and annual rates of change for urban and rural areas nationally, as well as by census region. This slide shows death rates for the 7 major causes of death. Let me walk you through one of them as an example. So if you look at the upper left, the chart saying cancer, the y-axis shows age-adjusted death rates per 100,000 population. The orange line is cancer death rates in rural areas. The blue line is urban death rates, and the national target line is in gray going across the chart. And it's constant because the national target is set for the whole decade. So for this chart, you can see that cancer death rates are higher than urban death rates throughout the tracking period from 2007 to 2017. Also, while both trends are decreasing, urban areas met the national target by crossing below the target line. Rural areas were decreasing towards the target but hadn't met it as of 2017. So looking at all the charts together now, you can see that rural areas had higher death rates than urban areas for all 7 major causes of death. And some of the rates were substantially higher, for instance, COPD and diabetes-related deaths. Also, rural areas hadn't met any of the national targets by crossing below the national target line. In addition to looking at target attainment, we also looked at annual rates of change as a way to summarize the trends. We found that rural areas had less favorable rates of change than urban areas for 5 of the 7 causes, and this would be seen as a widening or divergence of the trends. The 2 causes where the urban and rural death rates actually narrowed was unintentional injury and stroke, which are the 2 in the middle on the bottom row. This slide focuses on rural areas, looking at progress towards national targets nationally as well as by census region. The analysis we did here is that we looked at the change in the death rates between 2007 and 2017 in comparison to the national target. And we obtained the 4 progress categories you can see at the bottom of the slide. Starting from the left, the green check means that the rates crossed below the national target line and that targets were met or exceeded. The blue plus means that rates were improving towards the target but hadn't met it as of 2017. The yellow dot means that rates showed little or no detectable change, and the red minus sign means that the rates were getting worse or increasing away from the national target. So in the national column, you can see the finding that I mentioned, that rural areas hadn't met any of the national targets for the 7 major causes of death, in that there are no green check marks here. Instead, some of the rates were improving towards the target but hadn't met it, and some of the rates were getting worse. Progress towards the targets varied by census region in the rural areas. So you can see, as an example, COPD, which is the 5th row from the top, rates were getting worse in rural areas nationally, but showed little or no detectable change in the Northeast. They were getting worse in the Midwest and South, and they were improving in the West. We found that progress towards national targets varied for rural and urban areas between 2007 and 2017 for the 7 major causes of death tracked by Healthy People 2020. Rural areas had higher death rates than urban areas for all 7 causes. They hadn't met any of the targets nationally. Rural areas had less favorable rates of change for 5 of the 7 causes, and this led to a widening disparity. And rural areas had variation in progress by region. Examining these rural and urban trends nationally as well as at the census region allows us to identify differences that wouldn't be apparent at the national level, and we hope that these findings will be useful for policymakers and public health practitioners to identify health priorities for their community. Thank you.
And I can see why Alan chose to put me directly after Dr. Sirin, because my paper also plays off of healthy person. All right, it's been a long morning. Healthy People 2020 goals, because in the world of public health, these are what we look at. These are the things that we agree we should try to make better. And the findings of our study are, if you will, right there in the title. Our work at our center focused on one specific area, pediatric mortality. I'm a total sucker for kids. What can I say? And one of the things that spurred this paper was seeing a paper come out that says, wow, we're meeting all our goals for pediatric mortality in the US. And I'm like, wait, is that really true? Come, team, what do we think? Because if you'll notice, and again, I wish I could point, but there's in this little graph, on the extreme left is the target, and then there's a little red bar that I put in that shows you where the target is. And if you'll see, these are the targets that were set for Healthy People 2020 for mortality rates among children at different ages. And as you can see by noticing, the red bar is the whole US, the green bar is urban. Green for good, because if you'll notice, in each of those little bars, the urban people met and clearly exceeded the national goals by 2017. Now, come to the point that I'm going to talk about, which is the rural children. Those are the purple bars. And although it's a little bit less easy to see, but yeah, you can really see it, the purple bars are not close to that red line anywhere except for infant mortality, and that's just because on this scale, the infant mortality gap does not show. I'm sure Dr. Katy will be addressing this next. So the positive changes that we are seeing at a national level are entirely urban, and if we don't look for the rural children, we won't see what's been going on. And again, trying to summarize enormous quantities of data and addenda on the report, what is our takeaway? We're getting better, but we're still falling behind. We have been, as you can see, mortality among kids, this is good, has been declining over the past 20 years. But if you'll notice, back in 1999, we had a 17% gap between rural and urban kids. Now, with all the advances in medicine in the past 20-some years, we have a 25% gap. So the situation has gotten better, but the disparity has gotten worse. And in our paper, we cross-cut this several ways. I won't even go into all the details about minority children, other than to say, this nation owes a debt to American Indian children that we may never repay. But looking at some of the details, our paper also looks at some of the principal causes of death that would seem to be preventable by policy interventions. And these include intentional and unintentional injury. And we separate these out to show you that the picture is not always gloomy. There are some things that are very good for rural children. Because if you'll notice, that bottom blue dotted line is deaths of rural children due to assault. And they are and continue to be very low. Whereas the dotted orange line is urban deaths due to assault, which had been going down but seem to have crept up again at the end of the period. So there's a thing where rural are doing well. We aren't killing each other, which is helpful. Unfortunately, we're killing ourselves, because the top line is the suicide line. The top dark blue line is suicide rates among rural children, and these are children 10 to 19. You'll notice that was flat for years and is now going upward with an overall upward trend. The only reason that rural and urban disparities may be slightly coming together is that urban children are also beginning to kill themselves more. Not a good sign. There are also there's a lot of other causes. One of the things I always hear when I present about rural children dying, isn't that because of traffic accidents in rural? Yes, it is. That is unintentional injury are a large cause of rural problems, but there are policy solutions, we hope, for all of these. As you can tell, a little bit less pumped than I was in the morning because I'm exhausted. Now, Dr. Sirin could not really talk about policy because she's a Fed, but as a non-Fed, I can say, what do I think this means that we have to do? And there are three big causes that we need to address. First is unintentional injury, and I do have two very technical solutions, road design and improved EMS availability, but at the policy level, we need seatbelt and alcohol laws. We need seatbelt as a primary offense, including the seatbelt for the kid in the back seat, and we need alcohol laws that say zero tolerance for an adult with any alcohol in his or her system when driving a car with a child in it. Those are policy changes that we need to make. Intentional injury, suicide. There are interventions, they work while the intervention is there. Again, I think we need policy change. Gun control writ large is going nowhere, but there has been success with child access prevention laws, which state, among other things, if you have guns in your house, they have to be unlocked, they have to be in a locked cabinet, ammunition has to be stored somewhere else. Child access prevention laws are present in 27 states. If we expand that, we reduce the chance of children committing suicide with dads hunting guns, which is one of the sources of disparities between rural and urban. 46% of rural households versus 30% of national households contain a firearm. And I understand this. I grew up where hunting is part of your meat supply. But if you have your weapons properly stored and locked, a child cannot immediately kill themselves. And a delay increases the probability that they will not carry out the act. Child access prevention laws, enhanced mental health coverage, requiring that from the head up be considered. Health parity laws at the adult level have been shown to reduce suicides. There's no reason to believe that they would not have similar effects on child suicide. And finally, getting it in my last 30 seconds, better surveillance for rural childhood outcomes. Like I say, that big paper saying, we've done it. No, we hadn't. WNL from med school either means within normal limits or we never looked. And we can no longer afford we never looked for rural children. Thank you.
Thank you all for sticking around till the end. I appreciate that. I'd like to begin today by acknowledging the Nacotchtank and Piscataway people on whose traditional ancestral lands were gathered. I would also like to begin by acknowledging our funding support, which is listed here. Thank you very much to my co-authors, Carrie Henning-Smith, who acknowledged me earlier as a co-author on her paper, is also a co-author on this one. And we're going to talk about severe maternal morbidity and mortality and rural and urban differences. I wish I could tell you that I was going to speak encouraging words right now in the wake of what we've just heard about children and about overall mortality. I'm not, but I'm going to end with policy solutions because there's something we can do and there's something we have to do. I have only 3 slides, and here they are. Some of you may be aware that childbirth is becoming increasingly risky in the United States. Maternal mortality rates have nearly doubled in the past 2 decades. Every year, about 700 people die during pregnancy, at the time of childbirth, or in the year following childbirth. And an additional 50,000 people suffer life-threatening complications. This is unacceptably high, and not all people are at the same level of risk. Indeed, we've heard today about how rural residents are at greater risk of lack of access to healthcare services, as well as social determinants of health that can shape outcomes, including mortality. Our own research looking at obstetric care access in rural communities showed that between 2004 and 2014, 9% of all rural counties lost access to hospital-based obstetric care. By 2014, more than half of rural counties had no place where you could give birth. So in this study, our goal was to look at rural and urban differences in severe maternal morbidity and mortality, and also to look at predictors of those outcomes. We used national hospital discharge data from 2007 to 2015. So our study looks at maternal morbidities and mortalities that happen at the childbirth hospitalization. We are not looking at morbidity and mortality that happens during pregnancy or in the postpartum year, both of which are very important and comprise a big portion of maternal morbidity and mortality. What we found is that geography affects maternal health risks. Unsurprisingly, severe maternal morbidity and mortality has been increasing among both rural and urban residents. But what we show here for the first time is how much greater the risk is for rural folks compared with urban folks. When we controlled for sociodemographic and clinical conditions, we found that being a resident of a rural community was associated with a 9% greater probability of severe maternal morbidity and mortality. Over the study period, over the 9 years of data that we looked at, that adds up to 4,378 cases of severe maternal morbidity and mortality. These are moms who died or nearly died in rural areas simply because they were rural residents and not urban residents. That's 500 a year. If you're interested in a little bit more of the detailed information on the methodology, I would encourage you to read the paper, but what I want to focus on in my remaining time is the implications for policy and practice. This is the part where we lift ourselves up and do something about it. There's a lot that can be done here. We're having dialogue at a national level and at a very high level about what can be done to improve maternal health in this country. One of the crucial things that needs to happen for clinical efforts is to make sure that rural people and practitioners are involved in the development of clinical protocols and practices and best practices around improving childbirth care. Frequently, rural voices are not present at the table. We heard about structural urbanism at the beginning of this day together, and I think that is clearly affecting the way that clinical practices and guidelines are developed around maternal health in this country. Additionally, we need to focus on blood transfusion capacity in rural facilities. We did a little bit more digging into this disparity and found that blood transfusion accounts for a large portion of the rural-urban disparity that we uncovered, and so ensuring access to blood transfusion in rural facilities is crucial. And also, it's important that we listen to rural patients. There are so many rural pregnant folks that have one clinician, for their primary care, and then they have to travel really far to see someone for care during their pregnancy, and they may have to go to a different place to give birth, and they're transferred at higher rates. It's essential to ensure that patient concerns are heard when they raise red flags about what's happening for them. On the policy side, we need to ensure rural representation on maternal morbidity and mortality review committees. Currently, 46 states have such committees in place. Only 2 of those states, Pennsylvania and Texas, require rural representation. I served on Minnesota's Maternal Mortality Review Committee from 2012 until 2017, and there were no rural voices at the table, even though we had a higher proportion of maternal deaths we were reviewing from rural communities. How are we going to address preventability in rural contexts if we don't have rural people at the table that can interpret the data that we're looking at? Secondly, we need to ensure funding to address rural maternity care access and care coordination. There's a strong focus on this right now. Legislatively, the Rural Moms Act is focusing on this. We also need to address community response. And this is, I think this goes to the point that was made earlier around rural healthcare access as community infrastructure and thinking more broadly. There are many communities where rural hospitals closed their obstetric units and they will not open obstetric units again. The hospital no longer holds the risk of a birth gone wrong, but that risk doesn't leave that community. It stays with the families and people in that community. And so communities need resources to be able to provide safe spaces for birth and emergency obstetric care. And finally, Medicaid policy. Medicaid funds about half of all births nationally, and Medicaid funds more than half of births in rural communities. Medicaid is the financial lifeblood of rural maternity services, and there's a lot that can be done, from reimbursement rate changes and low volume supplements for rural communities to considering extensions of pregnancy-related Medicaid eligibility to 1 year postpartum. There are proposals that are circulating right now in Congress to discuss that, and it's being pushed by quite a few clinical groups. And additionally, expanding Medicaid coverage to cover non-clinical support services for rural people, including transportation and housing if you have to give birth far from home, other types of support, lactation support, doula support, other types of care and support that Medicaid policy can make available to folks. Thank you so much for your time and attention to this presentation and to all of this focus on rural health today. Thank you.
We'll leave that picture up while I ask some questions. This is going to be a bit of a tour, but please bear with me. Kenton, I'm really struck as I listen to your compelling presentation and the data, and then I go back to James Kirby's comments from a demographic perspective, saying that the disparity really widened in the 80s, and it's primarily tied to mental health and behavioral health issues. And these seem like very different stories. I'm not asking you to interpret his. It's not that there has to only be one, but I just wonder if you can help me try to make sense of these two really different ways of thinking about what accounts for the gaps.
Yeah, sure. I think you know, the first thing that comes to mind is probably the difference in the populations that we studied. So in my study, we focused on Medicare beneficiaries with one of the 5 major complex chronic conditions. Now, that is 60% of Medicare beneficiaries, so it's most of them. But for those people in particular, we didn't look at mental health issues. You know, a lot of them probably had comorbid depression, but for them in particular, seeing a specialist that was relevant to their disease condition in particular seems to be what's really important for them in treating those conditions. I think probably, you know, if you're looking at an entire population of people from age, 1 to 99, things might look different in a different segment of the population.
That makes a lot of sense. It's a good hypothesis. Let me get through them first, and then we'll bring in. So Scott, I have a similar sort of cognitive issue here. I was so struck when I read the paper, this notion that the rural population would have actually lived longer than the urban, controlling for these various factors. And again, I'm trying to map that to Jan, a couple of seats down from you, saying we have this structural problem, which is really about financing of healthcare services. It's not a structural problem just about economies. So again, when I listen to your work, when I read your work, I think we don't have a structural problem. We have a poverty problem. We have an income problem. But when I listen to Jan, I think, boy, we've got a structural problem. So again, doesn't have to just be one reason, but I just wonder if you could reflect on those two different narratives.
Wow.
Easy question. I always ask easy questions.
Okay, I'm going to solve poverty real quick. Right. Yeah, I don't know the answer to that except to say that of those 3 variables that we looked at, it was the socioeconomic one that was the strongest. That it was just, we looked at a whole lot of things early on, and it just came back to it's the poverty stupid. It's just how much it's wealth and income inequality in rural America, and that seemed to account for everything. But when it comes to all right, we have a field of dreams question, right? When it comes to rural America, it's like, let's say we get single payer, right? If we build that system, does that mean the rural doctors are going to come back? And I don't think that we know that yet. And that's an interesting question and a larger debate.
That's great. No, thank you. I know it was a big question. I appreciate just trying to get some thoughts going here. Carrie, striking findings, and yet I'm left with this question. most of the rural counties have no majority population.
Most
I'm sorry,
have majority
most have
white.
majority white. A large number have no majority.
Some, yeah.
So I'm sorry. Let me combine those two. I guess I'm really trying to get at the question of discrete versus continuous. So you've taken majority as sort of the defining factor. This is a majority, this county. But there's huge continuum both within the majority white and in the no majority, and frankly in the others as well. And I just wonder again if in your analysis you think there are implications to the continuous elements of this in addition to the discrete elements that show up on the map.
Yes. Can we do a whole health affairs issue that just looks at different parts of that continuum? It's way more than we can bite off in a single paper. Obviously, the measure that we used is incredibly blunt and very simplistic. I will put in a plug and say that we're doing micro data analyses right now to look at within rural differences by race and ethnicity, not just county level averages. Spoiler alert, the things sort of shake out the exact same way that I showed, but I think it's a both and. I think we don't have enough work looking at racism in rural health, and we need a lot more. So this is an incremental step there, and certainly not a stop.
Yeah, and I didn't mean to criticize. I was just trying to understand more than it was not a, oh, why didn't you? Thank you. Okay, so Sirin, you've already been called out as a Fed who can't talk about policy. So I don't know how far you can go with this, but I want to take Jan's comment and factor in thoughts that I had listening to as well about ARC has a disparities report, and so disparities are not an unfamiliar concept in thinking about this. How much are we tracking these differences, or is it sort of one-off to do the kind of work you're doing, the kind of work Jan's doing, and then we celebrate the aggregate? Or is there ongoing effort to try to understand the scope of these distinctions?
Yes, so I point you to healthypeople.gov as an online resource. One of the overarching goals of Healthy People is to reduce health disparities and achieve health equity. And towards that end, Healthy People has, for selected measures, data for different population groups, including urban and rural nationally, and for some selected objectives, rural and urban by state. And so they track these measures over the course of a decade. The 2020 decade started for these measures in 2007, and we've continued to track those measures over time. And Healthy People 2030 is going to be launched at the beginning of 2020, so keep an eye out for that. So healthypeople.gov for ongoing tracking of measures.
That's great, thank you. And so Jan, I guess my question to you, in addition to the policy suggestions that you had, you did say we need to improve surveillance, and I just wonder if you can go a little deeper in that. What don't we know?
I don't want to be mean, but somewhere I think that our first paper we say how many of the Healthy People 2020 objectives actually have rural subsets and particularly rural minority subsets, and it is relatively low, and I'm sure I grabbed your boss and yelled at him at a NRHE meeting to that effect. Like I say, if the national goals did not break things out by rurality for children, and they did not break it out by race. And some of the race data will play the way race data always do. There are some people who do well and some people who consistently do poorly because we have never provided them with the sorts of resources they need. I'm going to stop. That's all I got.
Okay. So Katy, I'm going to ask a slightly obscure question, but but I hope you'll use it as a point of departure because it really is too obscure. But we've published, we're not the only ones who know it, so we've published work on a state that's made significant progress on maternal mortality, and that's California. Mm-hmm. And one thing I'm struck by, going back to the very first panel, California has relatively few counties, given its large population. Yes. So if you do county-based analysis, it's really hard to, I mean, that's our biggest state, and we have counties not being a great unit of analysis. So when I think about your recommendations and how we could do better, I wonder if there are lessons from California that you're aware of, and if not, then use it as a point of departure to go somewhere else.
Yeah, thank you. An opening for a point of departure for discussion. So thank you for bringing up the California example. California reversed a rising rate of maternal morbidity and mortality in a pretty intentional and well-resourced way. They funded a data center for the state, and they also have a perinatal care quality collaboration. They are, it is a well-funded and intentional effort that has met with success by engaging first in data, in collecting and distributing and making data publicly available and transparent. Second, in engaging healthcare delivery systems. Third, in engaging Medi-Cal and the Medicaid program in California. Fourth, by engaging policymakers locally, from county public health up to state and federal legislators. So it was really a multi-pronged and well-resourced approach. I'm saying resources a lot because that's important. We need to start, as Jan mentioned, we need to start with the data. If we don't measure the differences, we don't know. And I will tell you, I have not seen data from California showing me the rural and urban differences in how those improvements have happened. And I would love to see, if we look at rural folks in California, we're talking about moving the needle here. When we look at that improvement, that's about moving the needle, and that happens with large populations. You can do that with large population centers. People get left behind. And we need to look beyond averages because they mask disparities. So I would be curious to see how things are in California for rural folks. And I agree that the county level as a unit of analysis is not helpful in places like the largest county in the contiguous 48 is in California and is an urban county with very rural areas. So I think that your point's well taken with regard to the county as the unit of analysis. And I think that brings us back to the work that Kevin presented at the beginning. What is rural? How can we recognize the diversity of rural areas and still move forward and capture measurement in a meaningful way that's comparable across studies so that we can do something and make a difference? And the data are necessary as a place to start. So thank you also to Health Affairs for publishing these data so that we can get started.
Thanks. Okay, we have a little bit of time. I'm going to not call on those who've had a microphone in front of them yet until we get some people who haven't. But I'm not getting a lot of takers unless the sun. Oh, the person who got cut off the last panel there, that's a good place to start.
Hi, my question is mostly for Katy, but anyone else can answer. In looking at California's successful reversal of maternal mortality rates, looking at Georgia as particularly the worst in the country, the worst of all developed countries, both those states have maternal mortality review committees. DC, I've looked at this myself, and I'm curious to understand what your thoughts are. DC has just started an MMRC last year. What would you recommend DC do if they were to look at California and then the pitfalls of Georgia? What would you recommend in order for DC to be successful in reversing their maternal mortality rates?
So I want to acknowledge that the Maternal Mortality Review Committee in Georgia is very recently convened, and they are working very hard to gather those data to be able to make some changes. With regard to Georgia and the Southeast, one of the things in our prior research on loss of rural maternity services highlighted the fact that counties with a higher proportion of non-Hispanic Black women who are reproductive age, holding all else constant, including provider supply, including Medicaid, including clinical conditions, holding all else constant, communities with a higher proportion of Black folks were more likely, rural communities with a higher proportion of Black folks were more likely to lose hospital-based obstetric services amidst a maternal mortality crisis that's disproportionately affecting Black folks. So there are multiple, this is where structural urbanism intersects with structural racism. And those are difficult tasks to overcome. It requires political will, and but first, to get the political will, you need both the data and the stories. And that's part of what the maternal mortality review committees are doing. There's great examples from the state of Tennessee, which has issued a wonderful report from their maternal mortality review committee on preventable deaths, focused on opioid use disorders, and on what can be done in the state to improve access to opioid-related treatment for folks after they give birth. And recently, there was legislation introduced to extend postpartum Medicaid to 1 year in the state of Tennessee based on that report from the Maternal Mortality Review Committee. That is policy action based on data, and I would love to see examples like that in the Washington, D.C. area where we have extraordinarily high rates of maternal morbidity and mortality. It's not the rural context, but some of those same systems and structures do come to mind. The same week that we published our work on rural obstetric unit loss, an obstetric unit closed in Washington, D.C., and created a maternity care desert in an urban area. So we need to not ignore both. It's both and. It's not either or. Thank you.
So if I can get some self-guided attention to those who haven't spoken. All right. Well, James, why don't you had something you wanted to jump in, and then we'll pull in a few others. But if we can get a microphone to James.
Who's raising?
Thank you. I know I've already had my turn. I just want to point out that Professor Johnston and Johnston's findings and my comments at the beginning are not as incongruous as they could be. Mortality is dominated by the large chronic conditions, heart disease, and cancer. But if you look at the widening of the gap, that's where mental health plays a lot. So, but mental health conditions are dwarfed by the large chronic conditions. So it's not really incongruous. And if my statement wasn't accurate enough, I wanted to make sure that
I appreciate that
was clear.
Appreciate that. Okay, let's go to Carolyn behind you. And
Hi, I'm a primary care physician, and this is a general question that addresses the whole issue. I retired from Bethesda Naval Hospital, and now I volunteer at the Arlington Free Clinic. It's a private clinic. It's mostly nurses, social workers, assistants. We have a full-time PA, and we have a full-time nurse practitioner, and a medical director who is a physician, and all the rest of us physicians volunteer. Our clientele is very poor, and probably a large percentage are illegal, or they're undocumented, and we have some very sick people. It's a good model.
I'm ready for the question.
Okay. Have you thought about federally qualified community health centers as a sort of a model with specialists coming in from time to time and something for acute, serious care, trauma, OB?
They're definitely rural models, so who wants to take that up?
Okay. I always have an opinion on everything. So I'll just say one thing. We do need more models, and we end our paper on structural problems saying we need more flexibility to think about my classic example is the older woman, dehydrated pneumonia, all she needs is 24 hours for hydration and antibiotics, and you can send her home, but you need the ability to be overnight. Does it have to be in a hospital? Mm-hmm. And I will also tie in that to a certain extent, FQHCs are models already of a subsidized utility. Now, while they are required to be nonprofit, in addition to the fee for service that they take in, they get a core to cover a part of their operating expenses. So they are being viewed as something that a community needs rather than that a person needs. And wait, I loved your phrase. When the hospital stops doing OB, the risk leaves the hospital, but it doesn't leave the community. I think we need structural approaches to keep community in sight when we think about money and what we're supporting. Don't know if that helped at all.
That's good. Let's come here. We'll go to here and Carl, and that's probably going to get us to time. So,
Lou Gagliano, Coalition to Transform Advanced Care. I want to salute everybody here who's working on this, and I want to leave you with a thought and maybe get a reaction. I think it's so important for the communication and best practices reviews to be important parts of your study, because the lessons that are learned in places need to be transferred throughout this country, because it will improve what we're doing in care. Thank you for your work.
Thank you. Let's get the, yeah, oh, right.
Good morning. Brett Miller from the Marshfield Clinic. I really appreciated hearing the structural urbanism point of view, but I wonder if, and I spent years and years and years fighting with CMS and HHS on the problems of Medicare reimbursement, because urban areas get paid significantly more than rural areas. And what I wonder is, do you have policy recommendations for supporting the utility concept for the rural areas? I haven't heard any of you come up with that yet, but I think that would be something that could move us forward.
How controversial do you want me to be?
You got 10 minutes.
No, I'll take 3. I'm sorry. One of my bête noire is MedPAC. I'm sorry, could I get rid of MedPAC? Who's like, take a deep breath. Could you ask your question again? It was, what are some policy recommendations? I think the answer is, instead of saying, oh, here's what we're paying them, until rural people are dying on the interstates, MedPAC will not care. But the question is not, are we maintaining our rural Medicare beneficiaries, who, by the way, are the people who already exhibit hardiness by surviving to the age of 65, doing equally. But are they really getting what they need? Are we paying rural clinics what it needs to keep those rural clinics open, rather than is our whatever mechanism that we're using right? If we were paying rural clinics equally, and this rakes to the point that you made to me earlier, you may have to pay rural clinics more than urban clinics in order to keep, who used the phrase, existence value? Mm-hmm. One of our previous, I love that. That was the greatest phrase. How are we going to keep facilities in existence if we budget around supporting a community rather than this nitpicky stuff? We may have to pay rural clinics more. We may have to pay rural hospitals more. All of the hospital advocates will be rolling in the street and I'm sorry, taking senators and congressmen to dinner as soon as we propose this, but I think it's the only way we're going to make change.
So I'm just going to say I think there's a payment and a public utility, and they're not identical.
Correct.
They're, and so anyway, we can take it afterwards, but I think it's important. Katy, you wanted to jump in.
I want to respond to that by thinking about this in both ethical terms and in technical terms. And ethically, I think we can either think about sort of a consequentialist approach or a process-based approach. And the outcomes we know. If we have a consequentialist approach, we know we're not doing right. Like that, we know that the outcomes are unethically distributed. Some people will point to some of the mechanisms that we currently have in place that are sort of geography neutral and say, well, everyone has the same process and everyone needs to, show the same quality and all of that. But the technical problem there is that if those voices, if evidence from those communities is not informing the process in the first place, if the decision makers in that process are not from these communities, most of the people that make our laws, that make our rules, that make decisions about healthcare and health plans have spent most of their adult lives in urban areas. And almost all of the clinicians that take care of patients have spent a lot of their adult lives or trained in urban areas. We have very few teaching hospitals and rotations in rural communities. And it's our evidence base for health policy making does not come from our rural communities. So how can we say that the process is fair? Ultimately, like the organizations like MadPAC, rural representation in any of these policymaking bodies, I'm not meaning to call them out. I'm speaking at MacPAC next month. So but being a voice and being a part of that, and not just me, right? I'm a rural girl at heart, but I live and work in a metropolitan area. I don't have to deal with the challenges unless unless I'm out visiting my parents. Of accessing care and the fear that's there, and when I'm managing my dad's post-surgical recovery. I know that, but I don't feel it in the same way that folks that live and work in rural areas every day do. And so we need greater involvement and integration of rural perspectives, experiences, and voices, and not just on the back end when we're repairing all the things that we've done wrong and coming up with policies to address the failures that we had in the first place, but right at the beginning as an integral part of everything that we do, because rural America matters.
Okay, last, yes, sir.
I had one thing to add to that. Sorry. One of our findings was that rural areas varied in their progress towards the national target. And this variation in the region suggests that some places have been more successful at addressing the disparities. So I just wanted to point out some of those bright spots that in rural areas in some census regions had met the national targets. So there's some opportunity there.
That's great. Okay, last quick question from Carl, and we'll wrap it up.
All right, so these are two research questions, but I have to preface them, unfortunately, with...
You got to go quick, Carl.
All right. So one thing that concerns me is somebody who... I've done 30 years of policy analysis on healthcare and long-term care, last 4 years, really focused on inequality and including the bottom half. So terrific research on the economic drivers, that disadvantage the rural areas, but I fear that it's going to overwhelm this internal market stories that could really inform policy. In other words, I do a lot of advocacy on mental health in Fairfax County. It's my experience that the people at the bottom of the heap have really big problems coming, in the jails and in the juvenile justice system getting access. So we need to also look at the question that are the disparities as big in the rural areas as they are in the urban areas? In other words, you could have more of a disparity in an urban area, but still have a higher level of care because there's so many rich people in the urban areas, okay? So that's one of the embedded questions. The other ones are like 7 seconds, Alan, sorry. That's why I suggested comparing poor people's care to poor people's care from rural to urban. There's always going to be inequality because of the system. Those two questions.
Yeah, so I think they're terrific. And I guess the question for this group is, to what degree can you look at the disparity differences urban-rural? I think it's a great question.
One of the reasons we did the study the way we did, so you can compare apples to apples across the country. You might want to dig into the data in the appendix that we've included, because we found them to be actually pretty comparable disparities. There's a lot there.
I also want to add just to that to say that being poor in a rural area and being poor in an urban area are fundamentally different things. And we need to look at rural places as they are, not like mini urban areas, or how can we get them more like urban areas, or because the challenges, the structural challenges of poverty in urban areas, if we look at, maternal mortality, which is an area of my expertise, is a prime example. We have moms dying in cities, and we have moms dying in the country. And a lot of those are Black and brown moms in both of those places. But the barriers that they face are very different, and we need to look at them differently in a different context that respects all of what it means to be rural. We can't, as Kevin said, we can't change geography, but we can change policy. And we need to be thinking about geography when we're thinking about policy. So it's not enough just to control for something or to look at poor people in both places. We have to look at those places separately in our work.
That's good. Okay. Thank you all for joining us for such a robust event. Before you get up and go, I do want to remind you that we had a unique consortium of support for this issue, and I want to acknowledge them again: the Robert Wood Johnson Foundation, the Colorado Health Foundation, Episcopal Health Foundation, Kate B. Reynolds Charitable Trust, Kanalma Foundation, Health Foundation, Empire Health Foundation, John A. Hartford Foundation, California Healthcare Foundation, and the St. David's Foundation. Please, I think we covered a lot of ground. Before we go, I want you to join me in thanking our final panelists. And we are adjourned.